Mark Keuchel, DO, many other accolades to his name, earned his Doctor of Osteopathic Medical degree from Oklahoma State University College of Osteopathic Medicine in 2013. He completed his emergency medicine residency at the Integris Southwest Medical Center in 2017. As the Associate Program Director at the Integris Southwest Emergency Medicine Residency, he is enthusiastic about medical education. He has been both a participant and a mentor in the Academic Life in Emergency Medicine Faculty Incubator Program. He was named the 2019 OOA Rookie Physician of the Year. He is also the Oklahoma Osteopathic Association and Oklahoma Educational Foundation for Osteopathic Medicine board member, as well as a regional trauma board member. Dr. Keuchel enjoys spending his free time with his wife and 2 young daughters. We are very, very appreciative of his time. And I got to reintroduce myself to him last year through board activities, and genuinely is a true pleasure to spend time with. So if you get a chance, take advantage and introduce yourself afterwards, okay?
Hi. They picked me to kick this thing off. It's a little nerve-wracking too, because I have a few of my mentors in the audience here. So Dr. McCullough and Dr. Pimsler, Dr. Taylor, I mean, really kind of all of you at some point have contributed to my education. So I'm really excited to be here, and thank you for everybody that's online with us. As you know, there's really a lot of things that we do in medicine that are just kind of because that's how we've always done it. And acute myocardial infarction care is one of those things. If you actually look at it, it has some really impressive history over the last quarter of a century, but we've really still just been doing the same thing over and over. The current guideline recommended paradigm of acute myocardial infarction, so STEMI versus in-STEMI, is irreversibly flawed. It's prevented meaningful progress in the science of emergent reperfusion therapy over the last 25 years. Deciding which patients need emergent reperfusion therapy is complex. Our current criteria for doing so is inadequate. The patients who benefit the most from emergent reperfusion therapy are those with an acute occlusion myocardial infarction or near occlusion with insufficient collateral circulation, whose myocardium is at imminent risk of irreversible damage without reperfusion therapy. This is the anatomic substrate that we know as STEMI. But it's the term STEMI that restricts our minds into thinking that an acute coronary occlusion is reliably diagnosed by only STEMI criteria or the ST segment by itself. In reality, STEMI criteria and the way we perform under the current paradigm have unacceptable accuracy. We routinely miss 25% of acute occlusions in those classified as in STEMI. So today, we're going to talk about how we might need a new paradigm. And I have no financial disclosures. And so today, what we're going to do is we're going to start out by really understanding how we got to reperfusion therapy to begin with, and then sort of what that has looked like over the last 25 years. Then we're going to talk about how the STEMI in STEMI dichotomy isn't good enough. And then finally, we're going to introduce the term occlusion myocardial infarction, OMI, or some people call it OMI. So to anyone that has spent time seeing patients, studying EKGs, maybe looking at angiograms of acute myocardial infarction, it's kind of obvious why the STEMI criteria fails in both directions. Foremost, an acute coronary occlusion is a complex and dynamic process that doesn't always manifest any EKG changes. And when it does, it's an intricate and time-sensitive progression of changes. When you look at an EKG at the very moment that somebody infarcts, they may have no changes at all. It's a dynamic process of reperfusion and reocclusion. In those early stages when an acute occlusion occurs, that's when the patient has maximal benefit from therapy. But again, you might not see any changes. And even if you are lucky enough to get an EKG during that time, the ST segment is always proportional to the QRS complex. Or the area of the heart may be a territory that has low voltage. Furthermore, not all acute coronary occlusions produce ST elevation. Some may only result in change of the QRS complex or the T wave. This is due to a variety of different reasons. So again, time that we recorded the EKG, the electrocardiographically silent part of the heart, small infarct size, previous infarcts, and low voltage. Meanwhile, there's a huge proportion of controls without acute coronary occlusion that have normal variant ST elevation. And we know there's lots of other ST elevations that are not acute occlusions. LVH, left ventricular hypertrophy or aneurysm. And we're not activating the cath lab for all those. So let's set the stage. You're on a shift in the ER. You have a patient come in, clutching his chest, complaining of chest pain. He's diaphoretic. You walk into that room and you can't wait for the technician or the nurse to print out that EKG because you've already got the cath lab on the phone. And they print it out, and it's pretty normal. There might be some subtle changes, but it's not a STEMI. And now you're sitting there thinking, do I know what I'm doing? The patient I'm looking at right in front of me is having a STEMI, and this EKG does not have a STEMI. So then you start debating with yourself, do I go ahead and still call the cath lab? Do I get maybe a troponin first and then call? Do I maybe just run the EKG by the cardiologist? Now think about this. What if I told you that in that scenario, you were using a decision rule that was wrong 25% of the time? If you'll think about other decision rules that we use in medicine, and I have to be biased on the ones we use in the ER, heart score for major cardiac event, less than 2%. PERC score for pulmonary embolism, less than 2%. So we're going to use a decision rule that is off 25% of the time? So let's remember where we came from. So a little over 25 years ago, we were using the Q wave, non-Q wave paradigm. And so we'd have somebody come in that we thought were having an infarct, and we really had kind of few therapies for that acute myocardial infarction process. We admitted the patient, we maybe put them on heparin, but basically we observed the patient while they had their transmural infarct. Then, if they survived, we classified their EKG whether they developed Q waves or not. Then, in 1994, one of the biggest medical research breakthroughs that we've ever had. The fibrinolytic therapy trialists did a meta-analysis of studies from 1984 to 1992, and it had almost 60,000 patients in it. And those patients were in studies that put people in a thrombolytics or a placebo group. And like I said, one of the most impressive studies ever performed, the number needed to treat was 56. So that's right up there with aspirin. Number needed to 56 is really good. We get excited when it's in the hundreds. What's more impressive, though, is that 4 of the 9 studies included in that meta-analysis had no EKG criteria. No EKG. They didn't use the EKG to make a thrombolytic decision. Half of them. And a third of the patients in the entire study had no appreciable ST elevation at all. So what do you do when you have a good study? Do a subgroup analysis. And so what they did is they said, okay, we know that giving thrombolytics is beneficial. Now, can we tease out maybe who has even better benefit from that? And what they figured out is that patients with ST elevation and a left bundle branch block benefited the most. Starting to sound familiar? This means that ST elevation predicted an acute coronary occlusion and thus mortality benefit better than not looking at the EKG at all. Furthermore, in that subgroup analysis, they looked at ST depression or normal ST segments, and those patients didn't show benefit. In medicine, said, welcome to the reperfusion era. So how'd they know who had an occlusion? Well, they didn't. All the trials in the reperfusion era couldn't predict who had an acute occlusion. They randomized high-risk patients to thrombolytics versus placebo without actually knowing who had an occlusion. Angiography was not used in these studies, just a concerning story for ACS, maybe some undefined EKG findings, and then they followed biomarkers. That means that the initial population had a high enough prevalence of an acute coronary occlusion that the benefit outweighed the harms in the non-occlusion patients. So what next? We fell in love with the term STEMI. The field of cardiology blossomed. We developed 24-hour cath labs, chest pain centers of excellence. Door to balloon time and many other factors became the primary determinant of cath lab activations and quality metrics. We were pretty happy with the advancement of STEMI. Think about it. We used to admit people and hope they survived. And now we have an intervention. But how did we get to where we actually are today? So again, that fibrinolytic therapy trialist study in 1994 was really the catalyst to where we are today. It proved that reperfusion was the way to go. So in 2000, the American College of Cardiology and the American Heart Association came out with guidelines for unstable angina. And this is where the official paradigm of acute myocardial infarction formally changed from Q-wave, non-Q-wave morphology to STEMI in STEMI. This was a great achievement. You went from looking at the EKG after the fact to actually making an emergent management decision based on the EKG right then. So although they had come out with that paradigm change, we didn't really have what the criteria were. So everybody got to work, and the first study to come out was in 2000 in the European Heart Journal. And what they did is they said, well, we got to figure out what are the criteria to use. So what they did is they had a group of healthy individuals and a group of acute chest pain patients. And they split them up into a training group and a validation group. And they used logistical regression to come up with the millimeter criteria, and then they applied that to the validation group. Also of note, they used biomarkers and CK and B at that, not angiography. What they decided was that we were going to go with 2 millimeters of ST elevation in the anterior septal leads and 1 millimeter in all the rest. So same year, 2000, the American College of Cardiology and the European Heart Society, or Society of Cardiology, came out with their joint first universal definition of MI. And what they did is they looked at the data from the fibrinolytic therapy trialist and that European Heart Journal criteria. And they said, yeah, we're good with that. So they went with 2 millimeters in V1 through V3 and 1 millimeters in all the rest. So like I said, a lot of people were really looking into what those criteria really ought to be. So just a year later, McFarland et al. Came out with their paper, and they said, hey, we kind of really looked into this, and we think that people's age and their sex might have something to do with their their normal variant ST elevation. And so that's what they did. They proved that age and sex commonly had different amounts of ST elevation in healthy individuals. At the same time, Wu et al. Performed a study and found that 2% of healthy Chinese males, no chest pain, no coronary symptoms, had 3 millimeters or more of elevation at the J point. So both these studies together said it's clear that any diagnostic criteria we use for STEMI must be based on the knowledge of these changes. So then 2004, a few years later, the ACC and the AHA came out with their STEMI guidelines. So before we were talking just myocardial infarction. Now they've come up with STEMI guidelines. And they said, we're going to go with 1 millimeter of ST elevation in any 2 contiguous leads. That's it. Pretty conservative. And this was class 1A for fibrinolytic therapy. A couple years later, McFarland et al. Said, all right, everybody, we have figured it out. We've crunched the numbers. We've looked at all the data. We've got it. We're going to go with 2.3 millimeters in AVL in 1, but it's going to be 3.5 in the inferior leads, and it's going to be 2.5 for V1 through V4. Oh, you actually also have to know their S to ST ratio, and we've got some other criteria in there as well. This is a quote from their study. Certain other restrictions apply. This study didn't use angiography. It correlated EKG findings with biomarkers. I know nobody's going to be shocked by this, but that's the last we saw of that study. So then in 2007, the American College of Cardiology and the European Society for Cardiology came out with their second universal definition of MI. And they said, okay, kind of what we did before, we're going to go with 1 millimeter of ST elevation in 2 contiguous leads, except for V2 and V3, which is going to be 1.5 for women and 2 for men. So they cut off that V1 and they just made 2 leads that you had to look at, but they made them different based on sex. In 2009, the American Heart Association, the Cardiology Foundation, and the Heart Rhythm Society all got together, and they came out with what looks like our current guidelines. And what they said is, okay, we're going to go with 1 millimeter in all the leads except V2, V3. And so we're going to go greater than 2.5 in men under 40, just 2 for men over 40, and greater than 1.5 for women. As I read that, I realize I'm getting ready to go into a new category. And then in 2012, the American College of Cardiology and the European Society for Cardiology came out with their third universal definition. And what they did is they adopted those AHA STEMI criteria. So everybody's on the same page now, 2012. There's actually a fourth universal definition out now, but that was mostly to address the use of high sensitivity troponin. But it does pay some lip service to ischemic EKG changes and echocardiography. So why might STEMI criteria not be good enough? So the main reason is we didn't really correlate with what we were looking for. These studies that we talked about didn't use angiography. They didn't actually predict who had an acute occlusion. Many solely used biomarkers, and CK&B at the time, now we don't even use that, we use troponin. It's not the difference in millimeters that we're trying, on a piece of paper that we're trying to find, we're trying to figure out who has an acute occlusion and get those patients revascularized. Let us not forget that STEMI is only one group of an acute occlusion. STEMI has been used as a surrogate for acute occlusion, but it's not everybody. And think about it this way. If I can't convince you that way, why do we have all these terms to get around the STEMI criteria? We're using subtle STEMI and STEMI equivalents. It's because we know the criteria is not good enough. And we also know that there's a lot of false positive ST elevation. So LVH, normal variant, I mean, we saw that one Chinese study, 3 millimeters of normal elevation. LV aneurysm, pericarditis, 15 to 35% of cath lab activations due to perceived STEMI on the EKG are found to be false positives. The current STEMI in STEMI paradigm prevents some in STEMI patients with an acute coronary occlusion from receiving emergent revascularization in spite of their known increased morbidity and mortality compared to in-STEMIs that don't have an occlusion. In those patients classified as an in-STEMI, the current paradigm routinely misses 25 to 30% of acute coronary occlusions. And it's those patients that have increased incidence of major adverse events. Let's look at some of the studies that back that up. We're going to start all the way back in 2001. Not like this just came out recently. Published in Chest, 2001. 1,800 patients with an acute MI were prospectively enrolled and underwent angiography. 418 of those 1,800 patients had an acute occlusion. 29% of those did not meet STEMI criteria. And the highest miss rate was in patients with an acute left circumflex occlusion. Next year, Keuchel et al. This is a pretty good study, a little bit smaller. And so what this study was now we have STEMI criteria and STEMI activations. So this study was looking at the hospital and their recent transition to a 24-hour cath lab. Remember, before that, we didn't always have 24-hour cath lab capabilities. And so what they did is they said, we're going to take our STEMI patients, obviously, to the cath lab, but we're going to include a group of in-STEMI patients that we think needs to go. And so they included in-STEMIs if the symptoms didn't respond to medical management. So they enrolled about 280 patients, and 125 of those were in-STEMIs. So of those 125 in-STEMIs, 47% had a TIMI flow of 0. 2007, European Heart Journal, a meta-analysis in which in-STEMI patients were prospectively enrolled and assessed for the prevalence of a totally occluded culprit artery. This meta-analysis had 7 studies with greater than 40,000 in-STEMIs. 25.5% had a totally occluded culprit artery. And in that study, it recognized the patients that had the acute occlusion had a higher short and long-term risk of major adverse cardiac event and death. 2009, American Heart Journal, post hoc analysis, okay, but 2,000 in-STEMIs, 27% had a completely occluded culprit artery. This is one of my favorite studies. From et al. 2010. What they did is they took 1,500 consecutive patients with a complete or near complete occlusion. So they already knew the diagnosis. They'd already had their cath. They then took those EKGs back and reread them, and 28% of them still didn't meet STEMI criteria. And they knew the outcome. And what's amazing in that is they actually only used 1 millimeter of ST elevation. 28% didn't even have a millimeter of ST elevation. Same year, 2010, Pride et al., American Journal of American College of Cardiology. This looked at patients with ACS presenting with isolated ST segment depression. 1,200 patients with ST depression were identified. 314, or 26.2%, had a completely occluded culprit artery. Most common one again, left circumflex. In 2012, Annals of Emergency Medicine, retrospective case-controlled study, 22% of patients with a proven LAD occlusion had less than 1 millimeter of ST elevation. So although people had mentioned it before, this is really around the time where the term subtle STEMI became more popular. It's also the time where people started hearing the term occlusion myocardial infarction. We had to name this subgroup of patients with an acute occlusion because it didn't meet STEMI criteria, but they had worse outcomes if they didn't get reperfusion therapy. 2014, Marty et al., American Heart Journal. This was a prospective observational study of 504 patients with persistent ischemic symptoms. So of those with a proven occlusion, 18% did not have a single lead with 1 millimeter of ST elevation. Just 2020, we added some studies to this idea of an occlusion myocardial infarction. So this was a retrospective review of acute coronary syndrome population. So 234 patients were diagnosed with acute myocardial infarction. Using the STEMI in STEMI dichotomy, 67 patients were included in the STEMI group and 167 in the in-STEMI group. So what they then did was they said, well, if we use occlusive myocardial infarction instead of STEMI, now how does it look? Now they have 108 patients in that same group that we would refer to as STEMI. So since only 67 of 108 met STEMI criteria, that actually means that 37% of patients with an occlusion myocardial infarction didn't meet STEMI criteria. Same group, Myers, just came out this year, a study with suspected ACS. And what they did is they compared this one was actually looking at the accuracy of EKG interpretations to predict. So they were using the OMI group or they were using STEMI criteria. And so they had 808 patients with 265 of them having an occlusion. So of the 265 that had an occlusion, 146 or 55% were diagnosed earlier if they used the terminology occlusion myocardial infarction, didn't just stick to STEMI criteria. Of those 146, 120 never met STEMI criteria on a subsequent EKG. That's 45%. Never met STEMI criteria, but had an acute occlusion. So this was the first one that actually published what they used to call OMI. So the first one was subtle STEMI. Okay, so subtle STEMI is just ST elevation that you can tell is elevated but doesn't meet STEMI criteria. I used hyperacute T waves. Reciprocal ST depression. ST depression maximal in V1 through V4. So that's catching your posterior STEMI. Remember, posterior STEMI, unless you get the posterior leads, doesn't meet STEMI criteria, to be honest. And I've done emergency medicine long enough to know that when you get those posterior leads, you don't get very good voltage. So you might actually not have elevation even on the posterior leads. Suspected acute Q wave, terminal QRS distortion. So instead of having a nice sharp change, you lose that. ST elevation and inferior leads, and then modified Scarbosa criteria. So, we can diagnose STEMI and left bundle branch block and paced rhythms. I think everybody in the room's thinking everything I've already heard a million times. The argument is that the RTCs haven't shown benefit in early versus delayed intervention for STEMI patients. We've all heard that. They're not exactly wrong, but that argument doesn't fully comprehend the literature. If the percentage of patients with an acute coronary occlusion is already low in a study population, so in the STEMI group, I'll admit, we've just talked about it, 25%, so only a quarter has an acute occlusion, then even a large mortality benefit will not be observed in these small RTCs. When we look through the literature, there's really three main reasons these studies don't show benefit. Number one, the early intervention groups weren't that early. Many of them were 14 hours, but others were 24 to 48 hours after randomization. In the largest study, the early group's mean time to intervention was 16 hours. Who wants to have an acute myocardial infarction and wait 16 hours for intervention? We care about less than 2 hours and really less than 90 minutes in most of these cases. One of the biggest trials cited is this TMAX trial. New England Journal of Medicine, obviously about as big of a journal as you can get, 2009. 3,000 patients, STEMI patients, were randomized, and they showed no difference. The early group was less than 24 hours, the delayed group greater than 36 hours. The mean time to intervention for the early group was 14 hours and 50 hours for the delayed group. 2017, the ICTUS trial. Early intervention group, the early intervention group was 24 to 48 hours. I don't consider that early. The other group was selectively invasive. Did I mention this trial also had an exclusion criteria for, quote, an indication for reperfusion therapy? (2003) ISAR Cool trial. It's hard to get much better of a name than that. Early group was less than 6 hours. Okay, not bad. Doing a lot better than most of our other studies. Delayed group, 3 to 5 days. Okay, so this study, they wanted to see if patients could cool off before intervention. They found in this study a significantly higher rate of death in large MI in the delayed group. But inexplicably, you know what the conclusion of this study was? The delayed group showed no benefit. Second major reason these RTCs aren't showing benefit. Almost every one of these studies excluded patients with refractory ischemia. Patients with an acute occlusion generally have refractory pain, and you're literally excluding the group that you're looking for. In the studies that didn't exclude patients, they showed benefit. 2016, CISCA trial, 170 patients, small, pre-hospital. What they did is they said a patient has an STEMI, ACS, we're going to randomize them pre-hospital. And the early group was less than 6 hours of intervention. Delayed group was just any time after that they felt they wanted to intervene. The early intervention group, I think, average was about 2.8 hours. What's notable about this study, though, is that they couldn't exclude patients for refractory ischemia. They were randomized pre-hospital, so they hadn't received maximal medical management. Primary endpoint, infarction, death, 2% in the primary group, delayed 24%. Don't exclude the patients you're looking for and you might find a benefit. Third, and it's a little bit on us reading, there's multiple studies discussing how poor we are at determining how much ST elevation is present. So McCabe et al. Got me and my friends together, and they published an article in the American Heart Journal. And what they did is they asked one simple question. They put an EKG down and they said, is there a blocked artery causing a STEMI? Gave interventional cardiology, non-interventional cardiology, emergency medicine, and EKG. Is there a blocked artery causing a STEMI? The inter-rater agreement was 0.33, which is terrible. These groups couldn't decide if there was a blocked artery causing a STEMI. This might be my favorite title. I'm actually upset I didn't think of it. Carley et al. Titled their paper, "What's the Point of ST Elevation?" I also liked the study also. Article in 2002, where they actually gave people EKGs and they said, mark the J point. That's it. Here's an EKG, here's a pin, mark the J point. 3 examples from their study. 29% correct, 61% correct, 13% correct. That's all you had to do, mark the J point. Couldn't even do it. Tanberg et al. Observation, variation, and measured ST segment elevation. Also love this study. Pretty funny. What they did, they gave everybody 40 EKGs. They didn't tell them that there were only 20 original ones. They duplicated them and then put them in random order. The average difference between the same person's 2 readings was almost 0.3 millimeters. And in a third, and in 20% of the time, the patient had more, or the person had more than half a millimeter of difference between their 2 EKGs. Then here's the kicker. When specifically asked, is there ST elevation greater than 2 millimeters, they disagreed with themselves 14% of the time. STEMI has become one of the most popular acronyms in medicine. Everyone knows what a STEMI is. Everyone knows how to treat it. For far too long, we've had to try to keep this familiar and catchy and beloved term STEMI in the name, when in reality, it's the name itself that's part of the problem. The term STEMI cognitively inspires us to think that only the ST segment matters, that the ST segments are reliable and don't depend on the preceding QRS, and that the ST elevation on the EKG is the only necessary data point we need to make a reperfusion decision. If we want progress on a larger scale in the management of an acute myocardial infarction, we have to be forced to break from our current paradigm. For 25 years, it's restricted our thinking, prevented further research from showing who actually benefits from emergent reperfusion therapy, and it's blinded us to how much better we can do for our patients whose myocardium is actively infarcting under our care. Is the patient having a STEMI must eventually be replaced with something that reminds us of the real question we're trying to ask. Does this patient have an acute coronary occlusion that would benefit from emergent reperfusion therapy? Our problem is that we have been so focused on the dichotomy of STEMI and STEMI that we've lost sight of what we're actually looking for. the acute coronary occlusion. And even if the ST segment was the only thing that mattered, the STEMI criteria doesn't account for these proportional changes. Data is starting to emerge that we are consistently missing a subset of occluded coronary artery patients. A new model may help us discover who could benefit from invasive therapy. For these reasons, the term occlusion myocardial infarction has entered our vocabulary. Occlusion myocardial infarction is defined as acute coronary occlusion or a near occlusion with insufficient collateral circulation such that the downstream myocardium will undergo imminent necrosis without reperfusion. The most important aspect of the name is that it reminds us what we're looking for. The acute occlusion, where the patient would benefit the most from reperfusion. It prioritizes the underlying pathology rather than an insufficient surrogate test. Results support that the occlusion myocardial infarction non-occlusion, rather than STEMI in STEMI, consistently identifies more patients with acute coronary syndrome who have an acute occlusion and salvageable myocardium. It's going to be uncomfortable for some people to change their mindset because STEMI in STEMI feels so clear-cut. But remember, it's not. We have all these workarounds. Moving to a new paradigm opens our mind to what's really going on, and it allows us to move forward in cardiac care. Hopefully, moving forward, we will see more studies linking EKG findings with actual angiographic evidence to give us a better idea of which patients need emergent reperfusion therapy. So here's looking to the occlusion reperfusion era. Thank you. Yeah, so I will say that a lot of the cardiologists, so the question is, what kind of are we looking at? Are we looking at some other things? And I would say the cardiologists have actually finally started to catch on to this a little bit more. I think when I was a medical student, it maybe wasn't as popular, but all the studies we talked about were in the cardiology literature. So now, if I have a patient in front of me who I think has an acute occlusion, I mean, they're diaphoretic, they look terrible, I'm just calling the cardiologist in the cath lab. I'm not waiting for a troponin. I'm saying, hey, I think this guy in front of me is infarcting. And I'll remember, you always have a story you're going to remember. And I remember this guy came in and he looked terrible. He was sweaty. I mean, I knew he was having an infarct. It's actually what inspired my original story at the beginning to set us up. His EKG looked normal. And I was like, this cannot be. I mean, something's wrong with the machine. So I called the cardiologist and I said, man, I get it. I'm looking at this guy. He goes, hey, if you're looking at him, I'll take him. He texts me back, 99% LAD lesion. I mean, we saved that guy's life. And his EKG was normal. So it's our favorite thing, clinical diagnosis.
Next speaker, wonderful guy. I've known him for 30 years, Dr. Walia. Got his Doctor of Osteopathic Medical degree from OSU, COM, in 2004, completed his residency at the OU Medical Center, following his pain management fellowship at Texas Tech University. Dr. Walia returned to Oklahoma to practice in his hometown. Board certified in anesthesiology and pain management. Dr. Walia's pain management practice philosophy is to relieve, reduce, or manage chronic pain and improve a patient's overall quality of life through procedures specifically designed to diagnose and treat painful conditions. When he is not managing pain, which the guy's a workaholic, I know, and needs to take a lot more time vacationing, he enjoys traveling, fishing, and time with his wife, Perdue, and his 2 children. Wonderful friend of mine, and I also forgot, thank you for all of you that are joining virtually. Please give us your feedback when you can. I didn't mean to neglect you at the introduction to the seminar.
Thank you, everybody, for being here. Appreciate Justin and the Oklahoma Osteopathic Association for inviting me. I've definitely been lecturing for many years since starting my practice. It has greatly increased since the Senate Bill 1446. As you know, there's requirements. And so I am in much more need than ever before. And so it's quite funny to get all these phone calls from folks. But I enjoy talking. I enjoy talking about pain management. Over the years of the Senate Bill 1446, and even just lecturing before, there's so many topics that I've discussed. It includes, when Senate Bill first came out, just the nuances of that. We've discussed how do you deal with a postoperative pain patient, especially for a lot of our surgeons who are super stressed out about how do I prescribe for this patient now with all these rules and regulations. We've talked about setting patient expectations. That was a big hit, always, how do you deal with that? How do you deal with that pain patient? The one thing that kept coming up every single time is, yes, the goal is to try to treat their pain, whether it's with less opioids or no opioids at all. Well, how do I do that? What options can you give me? What's out there? We all know a lot of the basics. So, after I got those questions, I can't tell you how many dozens and dozens of times over the years, I did some scouring of the literature, and Human Health, HHS, Human Health Department of Services, came up with a guideline of best practices. And so I wanted to review that today, but please know that this is super informal. If you have a question as we're talking about something, happy to answer it right now, because I'd rather answer it now so you don't forget, and it just kind of makes sense so everyone can understand too. Yes, it's working. Perfect. Okay, so opioid prescribing or opioid management has gone through a huge pendulum shift. Many of you have seen this over the years. Initially, we're prescribing it to everyone. That's the 90s, right? Opioid companies, government says, let's do it. Pain is the fifth vital sign. That's the way it was, right? Then eventually in the 2010 era, noted opioid deaths, noted opioid addiction, problems all around, came to the point that we're not going to prescribe opioids to anyone. And that's when I started my practice. And let me tell you, it was a little bit stressful. I show up, open my door over there on the Integris campus. And would you believe I had so many doctors who said, I can't wait. I'm so happy you're here. I don't prescribe a single opioid to anything. It's really not the best care, right? There are many acute situations that need to be managed mildly, not particularly long-term, right? But at least acutely. Now we've come full circle, right? We've got Senate bills on board with opioid prescribing. The CDC came out with guidelines that really hit us hard, and everyone was very fearful. To some truth to it, though, And now we came to this full circle of rational pharmacology, balanced care of pain management, and that's kind of where we are today. US prescribing rates, I'm pulling this back to 2017 just to show you a progression from 2017, 2018, 2019. So bear with me if you would, okay? But 2017 US prescribing rates, Oklahoma, right? We're in that second highest category. And by the way, this is retail prescriptions per 100 person. So we're not the highest as Alabama is there. We were the highest in 2014, but in 2017, we're not. So you see, fast forward to 2018, you even see a decrease in just prescribing rates in the country. Oklahoma is still in that category. And then you see even more in 2019, even more decrease just countrywide, right? But Oklahoma is staying steady where we're at. And I'm sorry, I'm having a hard time seeing this, so I'm going to turn if you don't mind, but I'm definitely paying attention to everybody. Once again, 2012, that's the highest national average of US prescribing rates. 81.3 retail prescriptions to 100 persons in the country, okay? And you see we've been coming down ever since. Oklahoma's highest was in 2014, and now in 2019, our national average is 46.7 retail prescriptions per 100 persons. We're still treating pain. We're using less opioids. I would even argue with our ER physicians if they were here asking the question, how much more are you seeing in the ER uptick of opioid, requests per se? I would ask our surgeons, how much of those are you having problems with your surgical procedures? A lot of them, at least the ones I've worked with in our system, we've come up with really good protocols for them. Hey, for this, this knee replacement, we pulled up some guidelines from Mayo Clinic. According to Mayo Clinic guidelines, here's what they recommend for tier 1, tier 2, tier 3 for the opioid prescribing for that knee replacement. Patient comes in, you give them that guideline. Hey, here's where we're at. If there's other issues and it's continuing, then maybe you need to see a guy like Dr. Walia or pain management and figure out where we are with this. We're going to break this down to U.S. prescribing rates by counties. Once again, I wanted to show you a global picture because it's going to be quite impressive. 2018, you see it's just dispersed. There's some counties that are huge prescribing rates. And according to HHS, they say there's 5% of counties in the country that if you calculate every opioid that they prescribe, every person in the US could get one prescription from those 5% counties. That's amazing. This is 2018. Here's 2019. And I'm going to put them side by side. That's amazing. Look at that. Such a dramatic change of US prescribing rates. And they're divvied up by counties. Let's pull up Oklahoma. Here's 2018. Obviously some hot spots. Oklahoma County, Tulsa County, they're the biggest counties, right? Not super high prescribing rates. What we noticed is there's high prescribing rates on the border, Oklahoma-Texas border. Change. Tulsa County kind of jumped up, but there's still some higher prescribing rates on the border of Oklahoma, Texas. Not sure what that means. Maybe Texas people are coming over, right? Maybe they think us at Oklahoma will give them anything. I don't know, but it's interesting. We've seen a lot of decrease in U.S. prescribing rates, even in our state. HHS, during this evaluation, and what they did is they took individualized studies for different groups of options in pain medicine, and they came up with this word cloud, okay? They sent out a survey after they reviewed all of these literature studies and searches and everything, and they came up with this word cloud. And this word cloud was sent specifically to pain management patients. What are your concerns about pain management? What are your concerns about going to the doctor? What are your concerns about going to the pharmacy and picking up your prescriptions? Where are your problems? And obviously in the word cloud, the bigger the word, the more it was replied in the survey, the more of the obviously concern. Surgery, neuropathic pain, migraine, stigma, it's huge. Quality of life. I see patients every day, and the hardest patients can be my pain medicine patients. My easiest patients can be my pain medicine patients. You just never know. It's so hard. I mean, I just today saw a guy right before I came up here, multiple myeloma patient who is having an incredible time with pain. His oncologist said, I've already prescribed enough that I can. His primary care just doesn't feel comfortable doing it. And the guy's in horrendous pain. And then when he goes to the pharmacy says, you keep filling a new prescription every week. There's something wrong here. We don't feel comfortable filling it. It's completely unacceptable. The guy's literally end stage dying, and he's having a terrible time getting pain medicines. They got to me today because I know their son. The son called me last night, said, can you please do something to my dad? Saw him today. I called the pharmacy myself. My nurses, help with my nurses. But we called the pharmacy, explained them the situation. They took care of it. We got him on some good medicines. Hopefully we'll get him better, but I'm going to see him back in a week to make sure it is keeping him comfortable, making sure it isn't causing any problems. And I have no doubt that the oncologist I'm sure they could do it. I'm sure they have tried, but there's some patients that just can be a little bit more difficult sometimes, right? And that's okay. I don't mind dealing with it. It's what we do. So here's what I'm talking about. HHS came up with this review of all these studies, and they came up with this big term, best practices, because they wanted to give us other options since we are kind of watching what we're doing with pain medicines, right? We're being a lot more careful. We're being a lot more smart about things. And these are easy things, but you may not utilize them possibly sometimes the way I utilize them. Acetaminophen, for example. I might give a patient a pain medicine twice a day with acetaminophen, but I tell them to supplement as breakthrough over-the-counter acetaminophen, obviously following the maximum amount. And sometimes that helps them pain-wise, decreases their prescription from 60 tablets to 120 tablets, doesn't make them so constipated, side effects, et cetera, that we're hearing about them showing up in the hospital, bowel obstruction or whatever. So there's little tricks that I do. NSAIDs, I use them. I don't use a ton of them, and I don't use it long-term. My brother's a GI doctor, and he tells me every time he gets called to the hospital in the middle of the night, GI bleeds. So he blames it on guys like me. So I don't use a ton of it, but it can be useful sometimes, obviously. We all know that. Anticonvulsants, gabapentin, Lyrica, these type of things. I use a lot of them. And I know there have been some studies and concerns, in regards to gabapentin addiction, overusing gabapentin, to the point that I've even had some primary care providers tell me, I just don't feel comfortable prescribing the gabapentin. I think that's okay. If you don't feel comfortable, that's okay. But I have seen a lot of value in it. I'm sure a lot of you have too. Antidepressants, we're talking about our SNRIs, our SSIs. Those are all incredibly helpful. So don't forget that you can use these medications, but titrate up accordingly and titrate down accordingly too. I can't tell you how many times the patients come in and said, I tried duloxetine, it doesn't work on me. I said, well, what did you try? And they said 30 milligrams for 3 months. I probably would have definitely increased it after the first month or even the first 2 weeks. So don't forget, you can increase these medicines, but that's okay too. Guys like me can do that. Musculoskeletal agents, obviously, are muscle relaxants. Super easy to use. It's just the concern is concomitant use with opioids, right? Sedative properties. So just always tell your patients, always document that there is some benefit of these agents, but long-term maybe not, and also the sedative properties. But I will tell you, a lot of what I see in my practice in the pain management world is spine, neck, and eventually those patients, their neuropathic pain can be controlled with our neuropathic agents. They undergo good surgical procedures that control a lot of their discogenic pain. What they're left with sometimes is a lot of musculoskeletal dysfunction, okay? And that's where they get confused that I'm having so much pain, and we got to push them towards increasing their core exercises, breaking that musculoskeletal problem, using these musculoskeletal agents. I see a lot of benefit, especially when I explain it to them more. Hey, I've got return of back pain. You want to repeat their scan to make sure, gosh, from their fusion or their surgical discectomy, it's not anything new disc issue. You want to do a good exam, but what you end up finding out that everything looks pretty normal as it did before. Most likely it's a musculoskeletal issue. Don't forget psych though, right? Stress, anxiety, etc. Anxiolytics. It's a big hot topic, benzodiazepines, right? I mean, that's a big concern. Benzodiazepines and opioid medications, CDC talked about it. Senate Bill 1446 talks about it. So definitely be careful with it, but don't be afraid of it either. I don't use it long-term by any means. There are some certain situations that I'll give short courses of Valium usually is what I'll use for some acute spine issues or acute surgical issues. However, I don't like to use it long-term. But if I have a patient that's on it long-term from their psychiatrist, and this is a patient that I've kind of figured out through the course of trying different medications or trying other things that an opioid is needed with it, then I talk to the psychiatrist hey, remember Senate Bill 1446 and the CDC say, you got to be careful. So I talk to them, right? And if they say, hey, we can try something else, let's try something else besides that benzodiazepine. If they say, I really don't think I can, then we just got to work with them. Document and work with them, and then start slow with that opioid and move upward. Opioids, I mean, literally, I'm sure every one of you have been opioid out with lectures, right? Because you have to, number one, since Senate Bill 1446, but just some easy, quick things to remember. Don't forget to do your risk assessments, simple things. There's some easy tools that you can get off the internet, whether it's opioid risk tool or SOAP-R. Just make sure you do a couple of them if it's a long-term chronic patient, okay? If you are following the Senate bill guidelines, you should be doing a patient-provider agreement. There's a couple nuances about it. Just make sure you're aware of them. Urine drug screening, I get this question a lot from my non-pain management doctors. Do I have to do a urine drug screen? Well, I mean, there's nothing that says you have to, according to the CDC or Senate bill, but I think it's okay to do. It doesn't necessarily mean much. I mean, you guys order blood work all the time. They're quite easy to evaluate the urine drug screen. So I think it's appropriate to do, but I can't tell you how many times I've had providers say, I just don't feel comfortable doing it. That's fine too. I think a pain management doctor would be perfectly comfortable doing it. Prescription monitoring program, we all should be checking it and are checking it. So I'm not going to talk too much about that. The only thing I will mention is if you're not routinely actually running a check on yourself, meaning checking what's being prescribed under yours, you should probably do that. I think it's less of an issue now that one of the laws is that you send everything electronically. Back when we were doing hard copies of narcotic prescriptions, it was much more of an issue of people kind of writing prescriptions under your name. I know I was definitely, it was probably every quarter I was having somebody do that where they were writing prescriptions under my name somehow, just forging a prescription pad from the hospital and just sending it out. Oh, these are some of the screening tools. Once again, super easy to grab off the internet, easy to put on your EMR, easy just to print off and do it by paper if you want to. These are just some frequencies that are recommended. Clinical reassessment just basically means when you're bringing them back in the office. And the reason I put Senate Bill 1446 and 848 was like, make sure you at least follow that at the minimum, okay? And it's quite simple. If it's, I think you're allowed to write a prescription and see them every 3 months for the first year. And then after that first year, you can see them every 6 months. So just follow that guideline. But I mean, there's nothing wrong with nowadays that we're doing telemedicine. You could do it, a telecall each month if you wanted to, and just kind of have a refresher and see how they're doing. I think this is just, you can just print this off, put this in your office if you have any concerns. Best practices, restorative therapies. I stress this a lot in my office. This is probably the biggest part of my conversations that I have with my chronic pain management patients. Because truly, once they're at that chronic state, you're talking about severe musculoskeletal dysfunction. They're having daily muscle pain. You're talking about the severe deconditioning that happens with them not working, not doing a whole lot around the house because they can't. So I'm always pushing maintenance physical therapy. I'm always pushing trying massage therapy, different type of treatment options. According to HHS in their retrospective review, they did say they put therapeutic ultrasound on this, but they definitely said they did not find any statistical value. It's weird. They didn't find any statistical value, but they're still recommending it. I don't recommend it. I just don't recommend it. Bracing was an interesting one back during my training time. Using spinal orthosis or back braces was kind of an end stage no-no in a sense. You don't give a back brace to a 70-year-old is what I was taught. But this retrospective review definitely changes things. And they say, there are some value in back bracing some of these severe spinal stenosis patients. but you don't have to keep them in the back brace 24/7. You could let them use it for short periods of time, whether it's 6, 8 hours, or even just, leaving the house and doing things. I've definitely changed my practice on that and started ordering a lot more of back braces than I ever have before, because my concern was always, I'm just going to decondition you. I'm just going to make you worse. But I've changed definitely, and I've seen some improvement with it, and I've seen patients benefit from it. But I do stress, don't use it all the time. This is HHS definitely sees value in adding interventional pain management to the picture of chronic pain management, especially the spine chronic patient, whether it's epidural steroid injection. These are just some pictures. Just basically cervical epidural steroid injections. These are patients who have discogenic pain and radiculopathies, and you're placing corticosteroids at that epidural space to decrease inflammation and calm this area down. I don't know what it is, but in the last 2 months, I have seen 6 doctors. Crazy. I mean, I see doctors often, but not like I did in the last 2 or 3 months. It was nuts. And you're talking about cervical radiculopathy, lumbar radiculopathy. And it's interesting, when you're hurting bad enough, you'll do it, right? And from what we know about surgery, none of us want to jump into surgery. So it can be beneficial, but there definitely are patients who fail it too, And that's what I do when I see patients. I tell them, there's 3 possibilities. You're going to be that guy who gets great results. I'm not going to see you for a long, long time. You're going to be that guy who gets great results, but it lasts short term. Or you're going to be that guy that it gets no major improvement. Well, guess what? Number 2 and number 3, we got to figure out another plan. We don't just keep doing it. We got to figure out another plan. Facet joint. This is something that we do a lot for axial pain, axial neck pain, axial back pain, non-radicular in nature, non-discogenic in nature. Good thing is, it's easy to do. You can improve these chronic symptoms, and you can eventually even do an ablation to that. Don't get me wrong, it doesn't cure that facet arthropathy, but at least keeps them trucking along. Sacroiliac joint injection. Dr. Stevens just left. He's one of our neurosurgeons, but I guarantee you he can attest to this. SI joint pain is so common that shows up as a pseudoradiculopathy symptoms in an office, especially in a patient who's had a lumbar fusion. That lumbar column is fused to the sacrum. The sacrum takes more stress and strain at the sacrum and the ilium, and the SI joint flares up like you wouldn't believe. Very common in the lumbar fusion patient. But you do not jump straight to it, right? You have a fusion patient. You need to make sure they didn't break a hardware. You need to make sure they hadn't ruptured another disc. You didn't make sure they don't have discitis in there. I get it. I do the same. But it's high on my differential diagnosis, sacroiliac joint pain. What we do in pain management, we do therapeutic injections, but we also do diagnostic testing for our spine surgeons, for our neurosurgeons like Dr. Stevens. So discography is basically testing of the discs. We're testing the discs, identifying the biggest pathology, especially when you've got a person who's having axial back pain, discogenic in nature, and then you have 4-level discogenic problems. I don't want the surgeon to fuse all 4 levels right off the bat. It'd be better if we could figure out which is the most symptomatic, which is the one that has the least pressure point, because we check PSI pressures of these discs. So that's a diagnostic. Radiofrequency ablation. That's where we're trying to get longer-term longevity of the axial neck or axial back pain patient who improved with the previous injections of facet injection. Simple to do, easy to do. I had a patient who came in. I actually am not even the one that recommended the radiofrequency. I think somebody else did in the town that they were living in, and their primary care doctor or whoever, I think it was nurse practitioner, said, I don't think you should do it. It's pretty invasive. There's a lot of recovery, cutting and sewing, et cetera. Somehow they ended up with me. We talked about it. And I said, it's all percutaneous. We're not cutting. We're not sewing. And, the layman term is burning of a nerve, but we're not burning it. We're sending radio waves and we're causing it to oscillate, and it just de-innervates that nerve for a period of time. Studies show after you de-innervate that nerve, it can last 8 to 12 months. There's some outliers on the 6-month mark. There's some outliers on the 18 and 24-month mark. I tell you what, you tell a patient that and they get that result, they're going to come back every year and have it done. Spinal cord stimulator implant, it's been definitely something we trained in my fellowship. We trained a lot on, but I did not expect to be doing as much as I'm doing now. And I truly believe part of it is the results we get from it sometimes, but also the push of less opioids and the more surgical spine patients we see. Of course, there's failures out there. But spinal cord stimulation is basically technology that was taken from the cardiac pacemaker. That's where it originated in the 60s and 70s, from the cardiac pacemaker technology. That technology was expanded, deep brain stimulation, spinal stimulation. We now have the InterStem for bladder and bowel stimulation. And there, if you're not aware, there's to be one for sleep apnea and pulmonary stimulation. Super interesting. So I think this type of technology is going to continue to advance in all of our fields of medicine. Sympathetic blocks. This is a lot of my orthopedic surgeons, a lot of my podiatrists see a lot of CRPS, complex regional pain syndrome. Back when I was training, it was called reflex sympathetic dystrophy, RSD. But if you haven't seen it, it's unreal. It is severe allodynia, severe atrophy, and it's a diagnosis of exclusion, which makes it even harder to put that label on. So you want to make sure that person who had that carpal tunnel surgery and is having severe hand pain and wrist pain, that it's nothing else. Let's see your hand surgeon again. Let's have them take a look at it. Let's make sure we're not concerned, but leave that CRPS diagnosis high up there, especially in the hand and foot. I see a ton of it. Interspinous process spacers have definitely grown in our practice. It is for spinal stenosis, lumbar spinal stenosis patients that have neurogenic claudication. I like to send them to a surgeon to make sure that they don't want to move forward with a multi-level decompression. But the best part about this spacer is it's minimally invasive. It opens up the canal, and it's about a 70% success rate. And it can avoid a big lumbar fusion. The other best part about it is if it fails, it takes a spine surgeon, neurosurgeon 30 seconds to 60 seconds to pop it out and move forward with their decompression surgery. It doesn't alter the options for that lumbar spinal stenosis patients. Behavioral health approaches. This is the hardest part of my practice. It's incredibly hard to convince a patient to try some of these modalities. It's hard to find coverage for some of these modalities. A lot of our colleagues, psychologists, some of them don't do all of these things. Whether it's because of reimbursement, I'm not sure. Whether it's because of time, I'm not sure. But it's definitely hard. So some of these things I try to do in the office and literally just sometimes have some printed sheets for patients and we discuss it. We'll sometimes just open up Google and do it together. Whether it's mindfulness, whether it's some cognitive behavioral therapy, some of these things are easy to do. Biofeedback, relaxation training. I love biofeedback. It's just hard to get someone to do it. Definitely relaxation training. So all of these are incredibly helpful. We've developed different types of support groups in my clinic too, where we are able to get psychologists involved where they kind of have multiple people all at once. So it's a way to also help the psychologist or therapist to come in. But I can tell you, I was a little hesitant to see how open some of these patients would be to it. But let me tell you, it turned out to be a blessing in disguise. It has been incredibly fruitful in my office. We get them together about every 2 to 4 weeks. They sit with the psychologist or the therapist, and they talk about their chronic pain issues. They talk about their psychosocial issues at home with family members dealing with a chronic pain patient, right? Because that's whole nother avenue. And at first, I did not think they would be as open to it, but they really, really were, and they continue to be. And it's been really, really good. And we try to talk about one topic each time to see what they can get from it in this behavioral health approaches. But it's definitely been a good cause, and we definitely are going to continue it. I doubt many of you guys are going to have such a significant patient population to do that. So I would challenge you to, at least at the minimum, pull some of this stuff up on the internet and just read it with them for a few minutes and just start to engage it a little bit and bring it up each visit and just kind of talk it through. Because sometimes it does take a little bit of coaxing. I know it does for us. I probably see these folks a lot more regularly than you do, but it definitely takes some coaxing on my part. Complementary and integrative health. I mean, I definitely think all of us know osteopathic manipulation, manipulation therapies have been amazing. I use it. I send my patients for it. We need more of it long-term, especially since there does take some time-consuming and repetitive treatment. So we utilize osteopathic manipulation quite a bit. There are some Medicare programs that have approved acupuncture, certain number of treatments of acupuncture per year. And I definitely have had patients utilize it. They definitely enjoy it. They definitely appreciate it. It is expensive overall, as you all know. I wish we could do more of it, but it's just expensive. So the ones that are on that program, I definitely push it. They wish it got covered more, truthfully, once they're done with it. Some of these other things, yoga, tai chi, spirituality, I know it may not make a whole lot of sense, or it may make a lot of sense to you, but definitely people who have a good home life, people who have a lot of interaction with family members, people who may have a spiritual outlet, always do better with their chronic pain. There's just no way around it. There's just no way around it. Best practices, always make sure you keep good medical records. I do a fair amount of medical legal work and have for many years. I will tell you the number one thing I see, and it's not the doctor doing it on purpose. It just happened where they see a patient or they've inherited a brand new patient who is on opioids and they're willing to take it over, and they have taken it over, and they said, hey, I'm going to get records from your last doctor, whether it's a primary care or even pain management. It's listed there. I'm going to do it. Really, fast forward monthly or yearly, I just haven't seen it. There's no record of it. There's no discussion of it. Do it. Make sure you review medical records, because sometimes you find things that you may not really believe, even though that patient's been a patient of yours for some time. I mean, I have a patient that I just inherited, and she's on her second month with me. The first month was that, hey, we're going to get medical records to figure out what they've done before. I'll take over your pain medicines. I didn't see anything wrong with the P&P. I didn't see anything wrong with any previous testing. I took her over, good faith, did that first prescription, did the urine drug screen, did the second prescription, and by that time, things came back from the records from an outside city, an outlying city from Oklahoma City where I live and practice. Huge red flags. Huge red flags. I was duped. She looked really a wonderful lady in her late 40s, 2 kids, take them to school. Everything looked appropriate. She had big back surgery. The record showed me huge red flags. So don't forget to follow up on that stuff. Don't forget. Obviously, we talked about P&P. Misuse, addiction, risk factors. These are simple stuff. We all know it. Just always put it in the back of your mind. I will tell you, the one that keeps coming up in the medical pain management world is tobacco. Tobacco use. Studies are showing more and more our heavy chronic tobacco users are obviously more inclined for opioid abuse, opioid use disorder, opioid addiction. Head-to-head studies have shown you have similar chronic pain patients. You have a heavy nicotine user, you have a non-nicotine user. The nicotine user uses a higher amount of opioid, no doubt about it. No doubt about it. And it's coming more and more in our literature in regards to tobacco use. I know some of our spine surgeons have even, started testing nicotine. Yes, part of it is for preoperative and surgical healing, et cetera. But, a couple of the lectures I've done with them before, they've come up to me afterwards and said, it's interesting. I've noticed the post-op patients I have a little bit more trouble with are the ones that we're weaning that nicotine or giving them Chantix to come off the nicotine so we could do the big surgery, et cetera. I've noticed that. That's crazy. I've noticed that. It's definitely coming up in the pipeline. Just a reminder, opioid risk assessment tools. Just a reminder of if you're going to do the urine drug testing, which once again, you don't have to, but it's appropriate if you want to kind of know the timeline of drugs left in the system. And obviously cannabis is a big one, right? Because we are now medical cannabis appropriate. Or is it even medical cannabis? Because it's just a recommendation. I don't know. I'm still confused about it, truthfully. It's a recommendation card, I guess. So be aware if you're going to run a urine drug screen, kind of what, if some positives come up, what you should be looking at. Know on your website, I think this is the old website, but know on your website that you can find this and other information in regards to pain management and the rules that you should follow about the Senate bill. Just know just some quick nuances. If you need a reminder, they want you to do a 7-day prescription. They want you to do a second 7-day prescription. They want you to do a 30-day prescription. So follow those rules, follow the patient provider agreement, appropriate timeline, et cetera. Goals, patient's understanding, improve level of functioning, modify the perception of pain and suffering, and obviously coping strategies for dealing with a disability and distress. My favorite part about my lectures are the questions, because if anything, there's a lot of questions. And it's usually about, hey, what would you do in this situation? Or, I had this patient in the office. So you're always, please feel free to ask me anything particularly if you want to now or off to the side. That's all I've got for you.
Dr. Bratzler is going to join us and give us a COVID update. He is professor and chair of the Department of Health Administration and Policy at the Hudson College of Public Health and professor in the College of Medicine at the University of Oklahoma Health Sciences Center. He assumed the role of chief COVID officer for OU in June of 2020. Congratulations and condolences. He also serves as the chief quality officer for the 3 hospital health system and faculty practice at OU Health. For more than 20 years, Dr. Bratzler has participated in research on the prevention of surgical infections and adult vaccinations. Board certified in internal medicine. He is also a master fellow of the American College of Osteopathic Internists and a fellow in the Infectious Disease Society of America, period. I got to spend 3 minutes with him and incredibly valuable insight in the 3 minutes I got to spend with him talking at the door. So if you get an opportunity again, please grab some time with him and let me stop spending his stage time. Thank you.
Thanks, Justin. Hey, good afternoon. It's really, that was the most hazardous drive I've made in a long time from downtown Oklahoma City up here. If you don't know, it poured, hailed, lightning. It was a long drive up here. I'm, as Justin pointed out, I'm the university's chief COVID officer, and I have to tell you, it's been the longest year of my career. So because I have responsibility not only for the OU Health Sciences Center, but the Norman campus, which has 25,000 students, and then the campus in Tulsa. So it's been a long year. What I'm going to do is give you a brief overview. I'm going to ask your indulgence. I'm going to go through some of the material real quickly. I'm going to make sure Audrey has the slides, that if somebody wants the slides, they'll be out of date within a few days, just so you know. But she can share the slides. So I'm not going to try to hit every detail of the material. And I recognized when I was putting this together, I put too much material in the presentation, but there are key points I want to hit, and I'm going to try to hit those with just a few slides. You heard that I'm a professor of public health. In fact, at the university, that is my principal appointment in the College of Public Health, and I teach students in public health. And in fact, we have a new bachelor's program in public health down on the Norman campus, and I teach the infectious disease public health portion of it. And I highlight that we live in a global community. And this is one of the slides I use when I'm teaching the freshmen at the Norman campus. This was the SARS pandemic that I remember from about 2003. And you don't need to go through the details, but there was a single patient in Guangdong province of China who got the infection, went to a hotel in Hong Kong, and then it spread throughout the world. And literally, it was an amazing impact. Over 8,000 people became ill, 774, 9.6% of the people who got it died. In fact, that's part of the reason the original SARS went away so fast. It killed off its people really quickly. There were 8 cases confirmed in the US, but all of them got infected from traveling in other parts of the world. So the point I made to the students is you can't stop the spread of a virulent virus with borders, with border controls and things like that. You just can't do it. You can't stop it because it's probably spreading before you knew about it. Then in 2018, we invited Sonia Shaw to come to the College of Public Health and give grand rounds. And this is a quote from her book that I love. It said, "The disease-causing microbe or pathogen that will cause the world's next pandemic lurks amongst us today. We don't know its name or where it will come from." That was in 2016. It seems very prophetic at this point. So we do know its name now, SARS-CoV-2 or COVID-19, which is a highly contagious virus that we know came out of China, probably was circulating in China as early as November of 2019. And of course, air travel between China and the United States wasn't cut off until January 31st of 2020. And so multiple people had already been in and out of China and were potentially exposed to the virus. And in fact, we know now that there were cases of COVID-19 in Los Angeles at the end of 2019. So it was already spreading in the world. We just didn't know what it was. Well, so it was December 31st of 2019 that China notified the World Health Organization that they were seeing this pneumonia that looked a lot like SARS. They detected it in Wuhan City. We started watching the numbers, and I remember we have a team at the university that started meeting. Our first meeting was on January 24th of 2020, and we brought together epidemiology, infectious disease. I was not the COVID officer at that time. We had our attorneys, HR, but we knew this wasn't going to be easy. And at that point, I made the point to a reporter that this just didn't look very good. It looked a whole lot like SARS, which we'd seen once before spread through the world. Nobody in the world was immune to it. It was spreading. We were watching the numbers in China every day, and they were going up really rapidly. So we predicted that there was going to be a pandemic at that point. In fact, we cut off all travel to China for the university on January 25th, and then the president did on January 31st. But we knew that this was going to be different. It was going to be very, very different. And in fact, you all know the story then behind that. The number of people infected in the world and in the United States has just been amazing. India's had the largest number of cases because of the Delta variant, which we'll talk about more in a moment. India reported 400,000 deaths during their peak, but some estimates are that 4 million people may have died in India from COVID-19 at that point. But here are the data from Johns Hopkins, 205 million cases in the world, 4 million deaths from COVID-19. If you just look at the US, 36 million cases in the United States and 619,000 deaths. And I know you're all really smart physicians and you know this isn't the flu. You've never seen flu do anything like this ever. It spreads, it's contagious, and it kills a lot of people. We've never seen anything like this before. In fact, it killed so many people that in 2020, it was the third leading cause of death, only behind heart disease and cancer. So if you look at this graphic and you look at this little portion of the graph where you see the red bump for the epidemic of influenza in 2018, you may remember we had an H1N1 outbreak. We had an epidemic of influenza. Now look at 2020. The red line is influenza, pneumonia, and COVID-19. And you can see this huge spike in the number of people infected with this respiratory virus. Again, became the third leading cause of death. In 2020 alone, 330,000 people died of COVID-19 compared to the flu that maybe 60,000 a year might die in a bad year. We had 330,000 people that we know of that died of COVID-19 just in 2020. And the overall life expectancy in the US was cut by 1.5 years in 2020. So unbelievable. So when's this going to be over? I know we all want it to be over. This is today's map of the spread of the virus. The darker the red, the more spread. You don't want to be in New Orleans right now. The spread is unbelievably big. Look at the panhandle of Florida. Florida as a state has the most cases per day in the country. Texas is number 2. And you can see that Missouri and Arkansas, which had been the real epicenters of the pandemic, have started to slow down. And in fact, here's the data from the CDC today. Louisiana has the highest number of cases per 100,000 population in the country. Florida, number 2. You can see Oklahoma is currently number 7 in terms of number of cases. In Missouri, that gave us Delta, is now number 10. It's dropped. They're finally, what we're seeing around the world and in the United States is this virus is so contagious that it's spreading through the population. It will infect almost anybody that is unvaccinated in particular easily. It'll spread person to person. You can't stop it, and then it'll burn itself out. The sad thing is it may be more virulent and kill more people. And I've got kids in my children's hospital, and this week I had 5 of them in the pediatric ICU with COVID. So it's a sad disease and nothing we've ever seen like it before. Well, this is data through today. So as of today in Oklahoma, we're 2,122 new cases a day on average. That's about where we were at last November before the big peak that devastated our hospital systems. And the point I make here is this is August 13th. Schools just opened this week. So there's just, I was talking to Dr. Hitzman here. It's inevitable that we are going to have outbreaks in schools. You can't keep Delta out. We can slow it with masks and vaccines, but it's virtually inevitable that we're going to see the cases jump. I suspect within 7, 10, 14 days max, we're going to see another surge in Oklahoma because we've reopened schools. If you look at the 7-day rolling average, which is the number I watch the most, you can see that we're on a steady trend upward in number of new cases per day, up to 2,122 today. And don't see that changing anytime soon. And the one that concerns me the most, this is hospitalizations in Oklahoma. And again, you can see almost exponential growth in hospitalizations. In the past 2 days, we've had 150 more people in the ICU. 150 more people in the hospital. About a third end up in ICU. If you look at published literature, the mortality rate, if you're COVID in the ICU, you have about a 50% mortality rate. This is a terrible disease. One of our pulmonologists said he's never seen lungs do what they do with COVID-19. Particularly if we go to autopsy, they're just filled with this gelatinous material and it just completely clogs them up. Here's the map that's become less impressive, but I've got a whole series of these maps. This is the community transmission map from the CDC. Any county in red is at very high spread of the virus. The kind of orangish color is substantial spread. Currently, CDC recommends that if you were indoors in a county that's red or orange, that you wear a mask, because this virus spreads so easily from person to person. And I'll show that in just a moment. But this is the community transmission map that the CDC provides. Finally, I want to say that the one difference I'm noticing in this peak of cases we're seeing now compared to what we saw in December, January, and February is that the people in the hospital are younger. 62% of the hospital admissions with this Delta virus peak, 62% are below the age of 65. Seeing a lot more 40 and 50-year-olds in the hospital. In fact, 55 to 64 is the largest number of hospital admissions currently in Oklahoma. This is Oklahoma data, by the way. So we're seeing this tremendous increase in the number of admissions in young people. Still about a third of the admissions occur in those people 65 and older. Well, what about vaccination? Will it protect you from being hospitalized? Yes, but we now know from very good data that the Delta variant will infect people who are fully vaccinated. When they get infected, they carry the same viral load as a fully vaccinated or unvaccinated person, and they can spread the virus to other people. So in part, that's my concern about schools, because even if the kids are vaccinated, and we've been polling the OU students coming back to the Norman campus this week, about 65% have said they're fully vaccinated. But we know that they can get infected with Delta and spread it. The one thing I pointed out on this particular slide, if you look at this is hospitalization data. This is Oklahoma data again. 93% of the people admitted to the hospital with COVID during this week, which was, I believe, August 1st through 7th. You can see 93% were unvaccinated. 6.6% were vaccinated, though. But look at the age group. Out of the 154, 115 of them were 65 and older. So I think many of you know that there's increasing evidence that antibody levels wane over time. So many of you probably got your vaccine early, December, January. And today, the CDC, or yesterday, they approved the delivery of a third vaccine dose to immunocompromised. And I think down the road, it's likely that 65 and older will have a recommendation for the vaccine for this very reason, because the breakthrough infections that are resulting in hospitalization still are predominantly in the elderly. If you're 85 years of age and end up in the hospital with COVID, you have a 30% chance of dying. 30%. 20%, I'm sorry, that's all cases positive. 85 and over, 30% will die. 20% end up in the hospital. Well, just to highlight, almost any symptoms can be a symptom of COVID. I've seen elderly people who have presented predominantly with things like decreased level of consciousness, decreased appetite, quit drinking, eating, things like that. So you have to be very cautious about that with nursing home residents and others. But the most common symptoms by far, at least with the original variant, were fever, chills, cough, and shortness of breath. That's what we taught everybody: fever, chills, cough, shortness of breath. With the Delta variant, the most common symptoms are headache, fever, sore throat, and runny nose. And of course, half the people in Oklahoma have allergies at some point, and sore throat, runny nose is really, really common. So we encourage people, get tested, get liberally tested. Go to Walmart, CVS, Walgreens, buy a simple Binax test kit and do it at home, but get tested. Because if you're positive, you don't want to spread it to other people. What are the risk factors for being in the hospital? Very clear, obesity is the number one risk factor for being hospitalized. Obese people do not do well with this disease. Chronic kidney disease, diabetes, hypertension all increase the risk. Hypertension is kind of interesting because cardiovascular disease, coronary disease, isn't that big of a risk factor, but if you have hypertension for some reason, those people are prone to hospitalization, and certainly asthma is a little bit of a risk factor. What about death? age. Clearly, this is a disease that kills older people. Again, highlighting that, yes, there are kids who die of this disease. We want to make that clear. But the percentage is very low, thank goodness. All right, so let's talk about some of the things we've learned in the past year. How do you spread it? You breathe it. Or how do you get infected? You breathe it. You don't get it touching the tabletop. CDC points out that the chance of infection via contact is 1 in 10,000. You breathe it. That's how you get it. You may not know it, but when you breathe, just sitting here comfortably in this room, just breathing, viruses coming out of your mouth, droplets and aerosols come out. More come out if you're yelling, more come out if you're singing, or obviously if you cough or sneeze, but there is a cloud of virus, or at least respiratory droplets around you all the time. And if somebody's close to you, they can breathe it in. People don't recognize it, but it's been demonstrated multiple times. So I'm not going to play this video. When we send out the slides, I strongly encourage you to go to this YouTube video and watch it. And it was a simple study where they took a professor and just said, say the words, be healthy. They used laser light photography, and they showed that a person without a mask, you could just sing the words, be healthy. The louder he said it, the more stuff that came out of his mouth, but it's stuff you can't see. You can't see it coming out of your mouth, but it does. And then they put a simple cloth mask on him, and it virtually eliminates the droplets and things coming out of his mouth. So I hear all of the arguments that masks don't work. I can tell you that the evidence is overwhelming that they do. The one that drives me crazy, well, the virus is so small, it can go through any mask. So obviously they can't help you. You don't breathe out virus, you breathe out droplets, and the droplets carry the virus. And so what you're trying to do is stop the spit from coming out of your mouth, the droplets, the aerosols. And if you happen to be wearing one and you're close to somebody, you want to stop it from getting in your mouth. So again, you get infected when you breathe in the droplets and aerosols that come out of someone else's nose or mouth. See so many people wearing masks that don't cover their nose, really of no value because the highest concentration of the virus is in the nose. So it doesn't help if you don't cover the nose. And this is the argument. I've seen all sorts. There's a doc in Indiana, I think, that's out there promoting this with all this scientific, evidence that masks cannot possibly work because the virus is 50 to 140 nanometers in size, and that's small enough to go through any mask. So they can't possibly help. But again, you don't breathe virus out, you breathe droplets out to carry the virus. So are masks perfect? No. But they dramatically reduce the risk of spread from person to person. And the other conspiracy that I hate is that masks will make you sick. There is zero published evidence to that effect. Multiple studies have been done now looking at COPD patients, measuring their oxygen levels, their CO2 levels, with exercise, without, with a mask on, no difference in their oxygen levels or CO2 levels. Just doesn't happen. This is a study from the Mayo Clinic that showed that if your distance actually does help, because a lot of times the droplets as you suck in are the larger ones that fall down on the floor. But if you're close, you can suck those in. So distance makes a difference. At 6 feet of distance, the risk of infection dropped down to 3%. If both parties were masked, drops down to less than 0.5%. So masks are very effective. Coupling that with a little bit of physical distancing, you can dramatically reduce the risk of getting this infection. There are some docs that I have to deal with every day, people like Jim Hogan, the GI guys that are in the mouth of people that, keeping them safe is just really hard. ENT doctors, they have to take the mask off the patient to look in the patient's mouth and nose. They're just high risk professions for getting infected. So healthcare has some real challenges. Second point I want to make, 6 feet is important, but it's not absolute. If you sneeze, it goes 23 to 27 feet. So it can spread a long ways. And CDC has put on their website this information about aerosol-based transmission of the virus. that if you're in an enclosed space with poor ventilation and you're doing things that make you breathe harder. So we just had a big outbreak in a gymnastics facility in Norman, Oklahoma, where a bunch of kids came in, competed in events. They weren't wearing their mask, obviously, when they were doing their routines, and oftentimes didn't put them on afterwards. Plus, one of the trainers was infected, and 43 kids in that gymnastics facility tested positive for COVID-19. So if you're exercising, singing may be the worst thing you can do in terms of spreading the virus. And that's one of the problems with restaurants. Because guess what? You have to take your mask off to go to a restaurant. You have to eat at the restaurant. So at OU, in the past week, I think we've had 3 meetings because we had opened back up, told docs that they could go to meetings. We have a 92% vaccination rate of our clinicians. We'd opened up our meeting rooms and we allowed them to have lunches at those meeting rooms. This past week, we had I think it was I forget which committee it was that was meeting. The chair of the committee turned up positive the next day, and everybody at that table then was required to go get tested because they were in the room with their mask off, eating a meal. We know fully vaccinated people can get infected. And the CDC formal recommendation now is if you're exposed to somebody, even if you're fully vaccinated, that you get tested 3 to 5 days later, regardless of vaccination status. So we tested all those people in that room. And yesterday we clamped down and shut down our in-meeting food. We don't allow them to have food in meetings anymore. They can take grab-and-go boxes when they leave. Here's a choir. This was a famous outbreak in Washington State. 2.5-hour choir practice, 61 people. They had 52 of the 61 that developed COVID symptoms, 32 confirmed, and 3 patients were hospitalized and 2 women in the choir died. They had hand sanitation, they did all that stuff, but obviously they did not wear their mask and they were singing. So I've had a number of music teachers around the state contact me, and I've encouraged them to double mask, open doors, windows, whatever they can do to protect themselves. Right, so let's mention Delta variant real quick. It's more than 90% of all the new cases in the US and in Oklahoma. It's much more contagious. It's very efficient attaching to human receptors. So if you're exposed to it, you're going to get infected. It's not clear whether the variant makes you sicker or not, although emerging evidence suggests, particularly in kids, it may make them sicker and faster. And the World Health Organization called Delta variant the fastest and the fittest of coronaviruses. Here's why it's so infectious. So if I'm infected, if I was infected with the alpha variant, the original one that came from China, I carried a viral load that could be detected, but it wasn't that big. But a nice study that came out of China where they took alpha variant infected people and then they matched them to Delta variant infected people. And by the way, China's getting devastated by Delta variant now. 1,260 times more virus in their airways than people who had the original alpha variant. It's just huge amounts. The other thing is the incubation period for Delta variant is much shorter, so people develop symptoms very quickly and start spreading the virus very quickly, sometimes before they even know they're infected. So it's highly contagious. It's very difficult. If you're in a room with people with Delta variant, it's going to spread quite rapidly. And you probably heard that CDC suggested that it may be as contagious as chickenpox in terms of this variant compared to the original one. So to kind of sum it up, the sheer amount of virus in the respiratory tract means that super spreading events are likely to infect even more people, and those people start spreading the virus earlier after they become infected. That was difficult for me to understand, but this made it clear to me. I started telling the press, it's kind of like Pigpen. You know, just think about it. You're infected with Delta virus. There's just this cloud of virus around you, droplets, aerosols, you're breathing, which you have to do. And you spread the virus. It's real difficult to not do that. What else do we know about Delta variant? This is the outbreak in Cape Cod, Massachusetts, you may have heard about. They had a multi-day event, mostly outdoors, interestingly, but lots of people getting close together in this outdoor event. Had 469 cases confirmed from this one event. 346, 74% of them were fully vaccinated. Fully vaccinated. They did genomic sequence on 133 of them, and it was Delta variant. But the other thing that I mentioned before is that when they compared vaccinated people to unvaccinated people who got Delta variant, the viral load was the same. Now, people who had those breakthrough infections that were fully vaccinated, 4 of them did end up in the hospital, but nobody died. But they can still spread the virus. And that's the challenge with Delta variant that we're dealing with right now. So I've told school boards, I've told Joy Hoffmeister, I've told the Commissioner of Health, I believe school outbreaks are inevitable. I don't know how we can possibly keep with students close together, unvaccinated, majority of kids in school, by the way, are unvaccinated. Without masks, we can't stop it, I don't think. I hope I'm wrong. So let me shift gears then and talk about these 3 things. Prevention, what can you do post-exposure, and talk about treatment. So prevention. First, there are no medications, vitamins, or supplements that have been shown to prevent the disease other than the vaccines. So up until mid-December, the only thing we could do was tell you to don't be exposed to the virus. Stay home, socially distance, wear a mask, those things, hand hygiene. Vaccination is very effective, and we'll talk more about that in just a moment. But when you look at the studies that were published originally for both Pfizer and Moderna vaccines, they were in the neighborhood of 95% effective at preventing symptomatic COVID-19 and 100% effective at preventing hospitalization. So against the Alpha variant, they were very, very good. But I tire, some of you may know, I do some social media around COVID. Pretty much once a week I post something. I'm getting so many instant messages now. And I'm frustrated what the patients are telling me that they're hearing from doctors around the state and around the country, to be honest, about all sorts of different things, that the vaccines aren't safe or that they aren't, and it's just incredibly frustrating. I had one that was 85 years old. The daughter contacted me. Both parents are 85 years old, and the doctor told them they shouldn't get the vaccine. In my opinion, that's malpractice. Because that 85-year-old gets infected, they have a 30% death rate. I'm going to talk about ivermectin in just a moment. Okay, so what about who? So let me see if I've got it here. I hope I do. Yeah, okay. Another one. I've had so many. So I had a former city councilman contact me this week and said his granddaughter, the doctor told her not to get the COVID vaccine because she might have birth defects. Complete bullshit. That does not cause birth defects, never has. And remember, the American College of Obstetricians and Gynecologists have fully recommended that all pregnant patients receive COVID vaccine. They've even sampled placental blood in utero and have shown that the vaccine does not get to the baby, but the mom's antibodies do. So it gives protection to the infant. Pregnant women, women of childbearing age should be vaccinated, because the study that was just published, and part of the reason CDC changed their recommendations this week, a study of 870,000 pregnant women in hospitals to deliver a baby, 499 academic medical centers. Women who got COVID at the time of delivery, if they came in and were COVID positive and were delivering, 15 times higher mortality rate than those that didn't get COVID, 14 times greater risk of being intubated, and a 6 times greater risk of being admitted to the ICU. So pregnancy and COVID don't go together well. Pregnant women should be vaccinated. Then what about people who have had COVID in the past? Had COVID, so I got natural immunity, it won't cause me any problem. Well, I'll just highlight 2 articles were published very recently, one by the CDC, and both of them showed the same thing. People who have previously had COVID do get breakthrough infections. People who have previously had COVID who get the vaccine have amazing increase in their immune response and are much more protected. The study from Kentucky showed that if patients, it was all patients who had previously had COVID, when they compared those that had gotten the vaccine to those that did not, cut the risk of breakthrough infection in half. So people who had not gotten the vaccine were 2.3 times more likely to get reinfected with COVID. So again, if you have a patient that's had COVID in the past, strongly recommend vaccination to protect them. Well, let's talk very briefly about vaccines. 3 different vaccines on the market right now. The 2 nucleic acid messenger RNA vaccines, Moderna and Pfizer, and then the 1 viral vector vaccine, Janssen. Novavax has been held up. Novavax is a protein subunit, kind of like trivalent or quadrivalent flu vaccine. Sanofi's vaccine has also been delayed. So what are the indications to get the vaccine? Anybody 12 or older should be vaccinated, period, unless they have a contraindication. So what are the known contraindications of the vaccine? There are only 2. And this is another one that drives me crazy. All the people telling me all the reasons why somebody told them they shouldn't get the vaccine. There are only 2 contraindications. First, severe allergic reaction to the vaccine. Can't know that until you get the first dose. And in fact, this nice study was published out of JAMA this past week that showed that even people who previously had anaphylaxis to the first dose, most of the time can safely take dose 2. So, and then an immediate allergic reaction to any of the components of the vaccine. And there are 2 that we worry about. Polyethylene glycol, I only know of 1 patient ever that I know of that's had a polyethylene glycol allergy. So Jim's doing a bowel prep on a patient for a colonoscopy. Polyethylene glycol is in the bowel prep. And I know of 1 patient that actually had a true allergic reaction to bowel preps. That's the only one I know about. You may know of others. But polyethylene glycol, that's in the Pfizer and Moderna vaccine. And then polysorbate 80 is in multiple vaccines. So if a person has had trouble taking other vaccines, I almost always point them to make sure they get an RNA vaccine because it does not contain polysorbate. There are way too many people out there that are being told that they can't be vaccinated or shouldn't be vaccinated. It's baloney. There are only these 2 contraindications to getting the COVID vaccines. So it's very, very frustrating. I had one of my former employees, a frontline RN, call me and said her doctor told her not to take the vaccine because she has true anaphylaxis to vancomycin. There are no antibiotics in these vaccines. There is no cross-reactivity to any antibiotic. So just remember that there are few contraindications to these vaccines. How do they work? I'm just going to highlight the RNA vaccines because when you look at all 3 vaccines, they kind of did the same thing. The tough thing that took these vaccines a while to get on the market was they had to coat them in something because that RNA, that little chunk of the viral that encodes the RNA that encodes for the spike protein, it had to, if you just inject RNA, it's destroyed in the body instantly. So they had to figure out a way to get it in you. So they figured out a way to put a lipid nanoparticle coating around it. That's what took time to do. When you inject this mRNA vaccine, it goes into the cell. It does not go into the nucleus. It doesn't get close to your DNA. So there are no DNA side effects. It goes to the ribosomes. Remember, ribosomes take RNA, convert it to a protein. The protein it makes is spike protein, that protein that you see on the picture of the coronavirus. Those spikes then get expressed on that cell and also are released into the circulation, and then your T and B cell system develops antibodies and T cell immunity against spike protein. That's how they work. It's pretty simple. The good news is there are no preservatives, no mercury, there are no thimerosal, there's nothing in these vaccines that the anti-vaxxers have fought against for many, many years. And the cell that that vaccine goes into, it displays spike protein on the surface and it gets destroyed. There's no remnant of the vaccine left. So I literally got an instant message this morning from a lady that was quoting a doctor from Ohio who told her that these mRNA vaccines had been programmed to kill you between 48 months and 2.5 years after you got the injection. There's nothing left. The vaccine is gone because the cell, your immune system, destroys the cells because they're now expressing spike protein, so they get destroyed. So incredibly, as one of my microbiologists at the university said, cleanest vaccines we've had, maybe the safest vaccines we've ever had in the United States. You've probably heard yesterday, FDA authorized today, the ACIP recommended that if you're immunocompromised, that you do get a third dose of the RNA vaccines. So I see quite a few in our clinics, transplant patients, renal transplants, liver transplants, and others. We've already known that those people don't mount a very good immune response, even 2 doses of the vaccine. So we now have recommendations to routinely give them 3 doses of the vaccine. What's that? Asthma is not considered immunocompromising, but if they're on, drugs for rheumatoid arthritis, lupus, some of the immunosuppressive drugs, or chemotherapy patients or HIV patients. Those are included. Anybody that's substantially immunosuppressed, I would recommend a 3rd dose for. All right, so we're talking about treatment now. So we're talking about prevention. So what about post-exposure prophylaxis? So I'm telling you, people are prescribing piles of stuff to outpatients with COVID, most of which have strong evidence that they are of no value or may be harmful. But there's one therapy that's now approved that's been shown to be clearly helpful that we don't hardly ever use, and that's monoclonal antibodies. Monoclonal antibodies have been shown to dramatically reduce the risk of getting symptomatic COVID-19. And you can give it as a sub-Q injection to the patient. So this is a study with 1,500 subjects, 753 randomized to the treatment arm, and you can see the graphic pretty easily, 76% reduction in infection with COVID-19. So what are these patients? These are people who are exposed to somebody known positive test and they're negative. So your wife comes home and she's infected from work. You're high risk. We don't give them to young people. We give them to people who are high risk, diabetics, obese people, people who are elderly. But you give the single sub-Q injection, it's actually 4 syringes, but you give 4 sub-Q injections or 1 IV infusion, and 76% reduction in the risk of COVID-19, post-exposure prophylaxis. So it does have an emergency use authorization for anybody 12 years of age and older, have to weigh at least 88 pounds. These are the criteria for identifying a high-risk person that you should be referring for monoclonal antibodies. So obviously older people, obesity, pregnancy, kidney disease, diabetes, patients that are on your immunosuppressive drugs, cardiovascular disease, lung disease, sickle cell, neurodevelopmental disorders are those that are just difficult that have trachs, pegs, things like that. How does it come? There's only one product that we use now, Regen-Cov. Comes in either a single vial with 600 milligrams of each of the monoclonal antibodies. We don't use BAM anymore. BAM doesn't work. Don't use it anymore. Or it comes as an IV infusion. But it's 600 of each monoclonal antibody, either sub-Q or IV. Effectively, 76% reduction in the risk of COVID-19. Underutilized, a lot of people don't do it. Now, what are they doing instead? Well, We'll talk about that in a second. The other point I want to make is that with COVID-19, remember there are two phases of the illness. So if you get exposed today, what happens first is the virus replicates, takes over, grows in your airways, gets into your lungs. It loves the lungs. It gets into your vasculature, causes blood clots, but it's viral replication in the first phase of the disease. In the second phase of the disease, when people get really sick, their oxygen starts dropping, they end up in the hospital, it's inflammatory. So the treatments are different. So when you have a patient, outpatient in your practice that maybe has some cough, headache, runny nose, positive test, what can you do for them? Well, these are the things that don't work. Antibiotics don't work. It's a virus. Nice studies with zithromycin showing no value. Corticosteroids, contraindicated. I see so many outpatients getting dexamethasone. It is contraindicated in outpatients because it can cause increased viral replication. Remember, the first phase of the disease, the virus is growing, so you don't want to suppress the immune system. So it's contraindicated. Vitamins and supplements, lots of people selling those, and ivermectin. I will tell you that I'm not opposed to ivermectin, but it should only be done in a clinical trial because there is little evidence of any benefit at this point. We need to study it, though, to find out. So I'll just run through these real quickly. This is a study of oral azithromycin. They gave them 1.2 grams, no benefit, did not change outpatients with COVID-19. And in fact, this study from University of Michigan talked about all the people that are getting prescriptions for antibiotics in the outpatient setting for COVID. It's a virus, it doesn't respond. Antibiotics don't help. I've had one patient with COVID-19 that was getting better. I was doing home monitoring. I had him on home pulse oximetry, which transmitted to my cell phone. And about a week into his recovery, and I thought he was about done, he started having more shortness of breath and cough, probably developed post-viral pneumonia. We did put him on antibiotics and he cleared up quickly. But most patients don't need antibiotics. What about zinc, vitamin C, and all those? Lots of people sell them, they don't work. Multiple studies have shown they don't work. What about vitamin D? Yes, there are studies that show that people with low vitamin D levels seem to have a higher risk of infection, but there's not a single study that shows that if you supplement vitamin D, that you will change that. I don't have a problem with treating somebody that has a low vitamin D level with vitamin D. I don't have a problem with that, but don't expect it to make a difference for their COVID-19. Ivermectin, this was the most recent randomized trial that was published in outpatients with COVID-19, 5-day course compared to placebo, randomized trial, controlled trial, blinded trial, did not change time to resolution of symptoms, just didn't help. So I'm not going to get into, because there's some people that are religious about ivermectin, and believe me, once I put something once on social media and was blasted in social media for you being an anti-ivermectin person. Here's the Cochrane review. I will tell you the Cochrane review found that there was some evidence suggestive that it might be helpful, but the confidence intervals were this wide. And it was just as likely that it was harmful. So again, there are some very good randomized clinical trials of ivermectin going on in the United States right now, and that's what I highly recommend. Ivermectin should be used as a part of a randomized clinical trial. The problem with COVID is, remember, the death rate, even for positive people, is 1.8%. So you could give them salt water, and most of them will recover. Most will recover. If you don't randomize, so you can tell the difference, you can't know whether the treatment works or not. That's the problem with ivermectin. So lots of people with testimonials, I got better, I got ivermectin, I got vitamin C, I got zinc. But again, most people get better. So it doesn't mean that that was the reason you got better. That's why these things need to be studied in good studies. The only other thing for monoclonal antibodies, again, now if a person is positive, has symptoms, They're not low on oxygen. It's contraindicated if their oxygen is low or they're hospitalized. We give IV monoclonal antibodies, particularly if they're a high-risk person. So if I have an elderly person that calls, I tested positive, I'm short of breath, that's the person I want to get in as quickly as possible for monoclonal antibodies, because about a 70% risk reduction in going on to hospitalization. So monoclonal antibodies work. They work. We don't use them often enough, but they work. Now, it's not something I encourage you to do in your office because you've got to be ready to treat anaphylaxis, but they work. What about inpatients? Well, beyond critical care, support fluids, oxygen, ventilation, and ECMO, which I'm not going to talk about. Yeah. Yeah, it has to be within 10 days. It's either 7 days or 10 days. There is a time limit, but it's important you do it as soon as you can. Because what you're trying now, remember, we're trying to stop the viral replication phase, and that's what monoclonal antibodies do. They go in and attack the virus that's circulating in your body. Yeah. I would, if they're a high-risk person, because previous infection, everybody's immune response is quite variable. So most of the time, we're not doing quantitative antibody studies. So if I have somebody who's high risk of complications of COVID and they're symptomatic, then I do recommend monoclonal antibodies. It's one of the only therapies in the outpatients that's been shown to make a difference. And now we can do it post-exposure before they even test positive. So I'm not going to talk about supportive care in the ICU, but that's incredibly important. And I think it accounts for most of the reduction in mortality from COVID. We know how to take care of them better with prone ventilation, low tidal volume ventilation, with all the things we do. And our center does ECMO, and once in a while somebody survives going on ECMO. But what works in the inpatient setting? Dexamethasone. Now, the patient's sick enough to be in the hospital and their oxygen's low, 6 milligrams a day for 10 days. Dexamethasone reduces mortality. Not in outpatients, it's contraindicated in outpatients. In inpatients, we do it. Okay? Lowers mortality, reduces the chance of them being on a ventilator. Remdesivir, I'm not a fan. Multiple studies now question whether it's of any value. This is a study from 2020. Back early in the pandemic, that showed a slight statistically significant difference in clinical outcomes, but questioned whether it was clinically relevant. Very, very small. Remdesivir, I don't think is a very good agent. And in fact, from the Cochrane review, Cochrane did a review, and they basically said that remdesivir probably has little or no effect on all-cause mortality up to 28 days, uncertain about the effects on clinical improvement or worsening. So I talked to my team at OU this week and I said, okay, a year into this, I had the critical care infectious disease. What works? Outpatient monoclonal antibodies, inpatient dexamethasone, and IL-6 inhibitors, the drugs like tocilizumab, and all the supportive care. There's not much that works in terms of helping patients. You can connect a JAK1 and 2 inhibitor to one of the anti-rheumatic drugs to remdesivir, and that may improve things. But again, it may be just because of the anti-rheumatic, anti-inflammatory drug. Because now remember, once we get in the hospital and lungs oxygen start dropping, we're in the immune phase of the disease. The body's attacking itself, filling up the lungs with that proteinaceous fluid, causing blood clots, and that's when the anti-inflammatories work. And then IL-6 inhibitors, you can see in this particular study, the only one that made a difference was tocilizumab, again, a drug used to treat things like polyarteritis, rheumatoid arthritis, and others. Tocilizumab helps reduce mortality. Finally, I'm just going to mention, I'm not going to spend any time talking about it, but the other reason I tell people you want to avoid COVID is long haul symptoms that occur in 25 to 30% of the people, adults that get it. 4 to 5% of pediatric cases have long haul symptoms. You know, they're really difficult. Some of you may be dealing with some of them in your office already. Fatigue's probably the most common symptom I see, shortness of breath, cough, joint pain, chest pain, brain fog. And then, I said the very first patient I ever saw with COVID was a distance runner who got COVID. His symptoms were shortness of breath and cough. He was really sick. And it took him months and months to regain aerobic capacity. Months and months. It really screws up your lungs. And you can look up this article. It's in Nature. It's on the web. Can't see it, but they've identified 50 different long COVID symptoms that can occur with the disease. It's sadly terribly common. Yeah. Brain fog is just what the most common symptom I hear is people say their memory is off. They can't remember things very well. So that's the big one that I hear about. Yeah. Absolutely. First, that's why I put it in the slide. The current indications for the vaccine is if you're 12. You're above the age of 12, I don't care what drugs you have, diseases, unless you have one of those 2 contraindications, you should be vaccinated. Underutilized. So let me end by just saying this. This is the 100-year pandemic. I'm in public health, principal appointments in public health. I never, ever thought I would be dealing with a pandemic of 1918 influenza proportions. Huge economic impact in this country, completely highlighted every weakness we had in our public health system. I really, in all the press interviews and other things that I do, I never criticize the governor, the legislator, or anybody else, because in my opinion, this is a virus, not a political issue. It's a virus, just like the flu, just like 1918 influenza. Doesn't matter where you live, what borders you cross, what your race, gender, it doesn't matter. It's a virus that kills people. So, but we turned it into a political issue rather than just a pure public health issue, and it's created huge problems. We did bring out the best in our medical innovation. Public health grand rounds in September is going to be Julie Ledgerwood. David knows Julie. She was one of our internal medicine interns years ago. She's the director of vaccine research at the NIH, and she'll be giving grand rounds for the College of Public Health here coming up soon. But amazing innovation to develop a vaccine and to get it on the market so quickly. Remember, RNA vaccines have been studied for 20 years, but they took that spike protein, turned it into an RNA vaccine really quickly. And despite all the improvements, sadly, this isn't over yet. And when I talk to our medical students, I tell them, for the rest of your career, you have a patient come in with shortness of breath, cough, fever, you're going to have to put COVID-19 in your differential diagnosis. I think we will, going forward, have an endemic disease with periodic outbreaks in unvaccinated or immunocompromised people. The cost of this disease is huge. We talked with the Commissioner of Health. They've been collecting data, but the medical bills for these patients is enormous. And CARES Act funding is largely gone. Some people are just completely devastated, can't go back to work oftentimes, particularly if they have bad long haul. We've seen people in the hospital for months. They're going to rehab and disabled. And I mean, the cost of this disease to our economy is incredible. That's why I think the most important things we can do are public health interventions, promote vaccine, promote wearing masks until we get past this big spike in the disease, and encourage people to be smart, to avoid big crowds, do things like that until this is over. I wanted to end by this, and I talked with several people about this, and I don't mean to offend anybody, but I'm just telling you, you better be careful about what you're saying in social media or even telling your patients. Again, I told you that when that daughter called me and said, both of her parents are 85 and the doctor said they didn't need the COVID vaccine. I said, in my opinion, that's malpractice. And in fact, this particular DO, this was publicized in Medscape this past week, is being sued because his PA didn't do the right test, ordered an blood antibody test instead of a PCR test. By the time the patient came back, they were quite symptomatic, and then the doctor put them on a muscle relaxant for some reason, and the patient died, and now the big lawsuit over that. I think liability is going to grow like crazy with COVID-19, particularly if people do not receive evidence-based treatments that are known to work and receive things that aren't shown to be helpful. The other one is, again, another DO, Dr. Chaudhry, who's president and CEO of the American Board of, the Federation of State Medical Boards that oversee all the medical boards around the country, basically said they're starting to encourage boards to take action against doctors that promote disinformation. So just be careful what you're putting out there and make sure you follow evidence-based guidelines and recommendations. It's a great pleasure to be here. It's always fun to get to come here and see some friends, and thanks for inviting me. Jim, did you have a? Which one's that? Yeah, we used a lot of them down on the Norman campus. So the question is about these rapid tests, the antigen tests. A positive test has to be repeated, but the negative predictive value of some of those tests is quite high. So you got somebody that's symptomatic, you do a good swab, they got to do a good nasal swab, and it comes back negative, it's pretty predictive that they don't have COVID. Comes back equivocal or positive, then you got a 7-4 PCR. Blood test only checks for antibodies. The problem is if you just order COVID antibodies, you usually get the nucleocapsid antibodies, which are meaningless. You have to do really quantitative spike proteins, which most people don't order. The blood tests are, in my opinion, no value for making a diagnosis, because if it's positive, it doesn't tell you anything. The patient may have been exposed in the past, may have been vaccinated, it doesn't tell you anything. So what you need to do is some type of either an antigen test or a PCR test. Yes, sir. Yeah. Yeah, so the question is, if you do take care of COVID patients, you need to be worried about air filtration, airflow exchanges. So we did a bunch of stuff at the university. A lot of our HVAC systems, we were able to change the air exchanges. A lot of HVAC systems allow you to bring in more outside fresh air. So we did that in all of our classrooms. We put higher efficiency filters in. We put in MERV 13, which are typically hospital-grade filters in our systems. I've seen in our ENT clinic, which are all aerosolized generating, we've put those portable HEPA units to suck in the air and run the air through HEPA filtration to reduce the viral load in the air. And then some HVAC systems are putting in either ionization or UV light. So we stopped in the university, we used to electrostatically, had the guys come in suits and spray everything every day. We stopped all that. It was costing millions. Probably exposed more people to carcinogens from the electrostatic spray than it helped prevent COVID. There's nothing wrong with wiping down surfaces, by the way. It'll prevent you from getting staph and other bugs. Yes, ma'am. Yeah, no, you can't order it. State Health Department issued rules today that says every lab in the state that does COVID testing has to send at least 10% randomly selected of the specimens to the public health lab for genomic sequencing. So the State Health Department decides who gets the genomic sequencing. It's done anonymously. You never get the results. You do not. Well, I mean, there is an anti-vax group that's out there that you're never going to, I don't argue with them, you're never going to change their minds. Those people, I just, I listen to them, tell them what I think. I don't try to get argumentative with them. I don't, if they're truly anti-vax. But, what I find a lot of times, we found what I call vaccine procrastinators that just, they weren't sure. And, FDA is probably in September going to give us full FDA approval for Pfizer vaccine. So hopefully that crazy argument that they're expecting, we've given 4 billion doses worldwide, but it's still, quote, experimental. And there's just a ton of conspiracy theories out there on social media, and people believe that stuff. Yes, sir. There is no virus in the vaccine. There is no virus in the vaccine. So even with Johnson & Johnson, it is an adenovirus that's killed that just carries a chunk of DNA into the cell. There is no live virus in any of these vaccines. You cannot shed virus from the vaccine. Yes, sir. No, yeah, it's a great question. So CDC's made it clear you can give them both at the same time. In fact, we give in our pediatric clinics, we give, HPV at the same time as we give COVID, we give other childhood vaccines at the same time.
Dr. Bratzler, we do have a couple questions online.
Okay.
Do you know the case rate in the Oklahoma City area? Are the children in the ICU on mechanical ventilation or ECMO?
Yeah, so I said that I think we had 5 in PICU earlier this week. One of them was on a ventilator. The others were there for critical care support and treatment. I don't know the case numbers for Oklahoma City. You can get those from, I could look up Oklahoma County. And you can look up Oklahoma City. I don't do it because there are too many cities in Oklahoma, but I do keep track of all 77 counties every week.
Next question. Will there be the potential of the virus dying off if people stayed home, avoided people, and wore masks? Or would the virus sit and wait and eventually infect most of the world's population?
Yeah, so I think that's a great question. So can you just hide from it? And will that make it go away? And I think there is some risk with Delta because it's so contagious that if it still exists in the population, it'll find people who are unvaccinated. You'll cross paths with them or other things. Most of us expect that, I still think we're going to see a pretty big peak after schools open. But at some point, our epidemiologic models suggest that cases drop off fairly dramatically, like they did in India, like they did in the UK. This virus spread so fast that it will run out of people to infect. Then we have to worry about the Indonesia variant or the Brazil variant or the, whatever variant comes next.
Please explain why and how the third dose will help. Are the vaccine efficiency waning in immunocompromised patients?
So immunocompromised patients, particularly organ transplant, even with 2 doses of the vaccine, about half get no antibody response. If you give them a third dose, about 25 to 40% of them will develop an antibody response. So it's not great, but it's better than not giving them the third dose. So I actually have a transplant patient who has now had 3 doses, still has no detectable quantitative spike antibodies, and now is looking about whether she pursues a 4th dose.
We have one last question. I have seen UC and ER patients with COVID pneumonia being sent home on Decatron and Zithromax. Please advise.
Yeah, so if a patient is hypoxemic and you're sending them home on oxygen, then Decadron may make a difference. And I told you that I had one patient early in the pandemic that we used the Massimo system, that I actually kept him on a continuous pulse oximeter at home. I literally could pull him up on my phone anytime, day or night, look at his current pulse oximetry, his pulse rate, and his blood, just gave me continuous monitoring. So there may be on occasion a patient that might be in an outpatient setting that's particularly if they're hypoxemic and they're using supplemental oxygen that might benefit from dexamethasone, but do not prescribe dexamethasone to people in the outpatient setting because it may actually make the virus grow faster. I think there was one more question, and then I know there's another. I'm running over their time. Go ahead. Yeah, so, there's some evidence. So I think corticosteroids if the patient is short of breath and has hypoxemia may be useful. But most of the time it's just supportive care because it's a viral illness like a cold or the flu. And most people, other than ibuprofen and maybe a decongestant, you don't do a whole lot for in that setting. There just hasn't been any proof that most forms of treatment have made any difference. The big difference now are monoclonal antibodies. They're underutilized. Your hospital, I would strongly encourage them to figure out a way to set up the infusion. You do need to have a nurse or somebody that's there, that's ACLS trained, because there are rare anaphylactic reactions to monoclonal antibodies. So you have to be prepared for that. That's why I tell people it's probably not something you're going to do in your office, but you need to be, we just underutilize it. And yet it's, in both of those studies, around 70% reduction in hospitalization. It's dramatic. It's great to see all you get. Yes. Yeah, that's a great question. Pfizer is already testing a modified virus, a modified vaccine that has RNA that encodes for the spike protein for the Delta variant. So that may be another reason that people end up getting a booster in the future. Delta may go away though, just to be honest. Right now we're worried about Lambda, but it seems to be decreasing. So sadly, as long as it keeps spreading in the world, we can have another variant. Thank you all. It's been great to see everybody.
Our next lecture is going to come from Jed Perdue, MD, MPH. He is the medical director at Arcadia Trails Integra Center for Addiction Recovery, dually board certified in addiction medicine and psychiatry. Dr. Perdue specializes in treating addictive illnesses, psychiatric illnesses that co-occur with addiction, and psychiatric illnesses co-occurring with complex medical problems. Born in Ardmore, Dr. Perdue graduated from OU in 2000 and OU College of Medicine in 2004, completed his residency in psychiatry at Duke, where he also served as chief resident. He's been active in clinical practice in Oklahoma City since 2008 and has served in various leadership roles for health systems and medical societies, as well as an instructor of medical students and residents. He serves as adjunct faculty for the Department of Biostatistics and Epidemiology for the Hudson College of Public Health and the Department of Psychiatry and Behavioral Sciences at University of Oklahoma. I've only known Dr. Perdue for a couple of years. It's been a fantastic relationship. And as he's an addictionologist, I can tell you he has helped me with some of my most heartbreaking and most challenging cases. We all have a lot to learn from him. I've also been chastised that I failed to mention, and I just can't beat the comedy in this, that the hospitality suite is now open. So, thank you.
Hi, and thank you all for your time and taking some time out of your Friday to hear about another epidemic, right? I know that we've been talking and listening to Dr. Bratzler's expert commentary on COVID-19. And, I'm going to be, sharing my observations on a different epidemic, that is the epidemic of overdose deaths and more broadly addiction. In terms of my learning objectives, mainly, I'm going to talk about recent trends in addiction and overdose deaths, talk about some of the factors that are driving that increase in overdose deaths, and then look at some strategies on how we can decrease those deaths. Disclosures, really the only thing is that, I am the medical director of an addiction treatment center, but don't worry, I don't have any promotional stuff up here. So, first off, I think it may be helpful to talk a little bit about terminology, because I may use some things interchangeably, but really they're not. So when we talk about addiction, I love this this definition by Dr. Keuchel, where it describes addiction as a chronic relapsing disease of the brain triggered by repeated exposure to drugs in vulnerable individuals because of genetics and developmental or adverse social exposures, because it really captures those different drivers for addiction. And I'll often share that with my patients when I'm working. Whereas a substance use disorder, really, that's a little bit more of a broader term. And we use that term to describe the use of a substance that's accompanied by symptoms of impaired control, preoccupation, especially that's causing some social withdrawal, risky use, and or physiologic dependence, sufficient to cause some type of functional impairment, whether it's impaired relationships, impairments at work, impairments in educational pursuits. So if I were to draw a Venn diagram, what we would find is that the addiction is contained within substance use disorders, but there are some people who may meet criteria for a substance use disorder that aren't biochemically addicted. And if we look at the DSM-5 criteria, we can really break them down in those four main areas of impaired control, preoccupation, risk-taking behavior, and physiologic dependence. I won't read these one by one. You've all seen them. I must admit, even I have like like an epic quick text so that I can bring them up, because they all kind of mesh together. But it is important to look at them, consider them one by one, because that's also how we define severity. So if we're saying that someone has a mild substance use disorder, that's someone who meets 2 to 3 of these criteria, whereas a severe is 6 or more. Now, if we look at what things look like prior to COVID, what we found is that we're actually making some progress in some areas. Rates of alcohol use and alcohol use disorder had been decreasing across time. Still problematic. Over 25% of individuals engaging in binge or heavy drinking, but over time had been decreasing. Also decreasing rates of opioid use and opioid use disorder. Now, the story wasn't quite as positive for cannabis use, which had even prior to the pandemic had been increasing at a slow but steady rate, as well as methamphetamine use and methamphetamine use disorder. Now, looking at overdose deaths prior to the pandemic, even though the numbers were still substantial, we were starting to see some progress here. We were starting to see a plateau in the curve. So, if we look at 2018, there was a slight dip in number of total overdose deaths. In 2019, slightly elevated, but it had sort of peaked in that 68 to 71,000 range. And if we look a little bit more closely about what some of the drivers for this increase in overdose deaths across time, what we find is really, it's been a story of different waves. So the first wave of the overdose death epidemic was driven by, of course, prescription opioids, which we've all heard probably 100 lectures about, and so we see that in the 90s, early aughts, really being the principal drug involved in overdose deaths, and then in that 2010, 2011 range, we see really a plateauing of the prescription opioid deaths, and then an increase in heroin-related overdoses. Of course, as supplies of prescription opioids began to dwindle, we saw more people shift over to using heroin, which of course is quite deadly in overdose. And so that became a principal driver until about 2015, which rates began to level off and slightly decrease, although still substantial. And then this third wave, which we really see around that 2014, 2015, really take off. And in the same way we look at those COVID-19 graphs and we see that steep slope as a harbinger of really difficult times, we've seen this with synthetic opioids. Of course, we've all seen the news reports about synthetic opioids, especially fentanyl and fentanyl analogs, but we can see that has continued to climb and has not even began to level off. And that nationwide has been by far the principal driver for this increase in overdose deaths. Of course, then comes COVID. And when we look at, just in general, the impact of COVID in our communities, in our lives, it's affected everyone in a myriad of ways. Whether it's direct health impacts, whether it's grief related to losses, and more broadly, grief related to losses in our community. We see loss of supports, employment, economic challenges, missed events, missed opportunities, limited healthy coping strategies, especially during those times in which we were more locked down, and then isolation. When we look at how those impacts have translated into symptoms, the CDC has conducted a weekly screen of anxiety and depression as part of their pulse survey. And they began doing this in May. And they'd had a similar study a couple of years prior. And so those dotted lines on this graph represent kind of what those baseline numbers were. And for just combined both anxiety and depression, is around 11% of the population. So if we look at where things have been, really, beginning in May of 2020, there is a substantial increase across time. So, those numbers have ranged from the mid-30s on up to the 40s. And, most concerningly, even though there's been some peaks and valleys, and at least towards the end of May of this year, it had been declining, nowhere near pre-pandemic levels. So really, this speaks more broadly to a broad level of distress among our communities. Now, what do people do when they're anxious or depressed? Well, unfortunately, a lot of people turn to substances, and survey data supports that. If we look at some of the early surveys that the CDC conducted back in June of 2020, about almost 1 out of 5 individuals said that they had either started using substances or had increased their use in response to pandemic-related stress. A follow-up study in September showed about 15% reported increase in their substance use. And then a more recent study, which was conducted by the American Psychological Association, showed that just looking specifically at alcohol, that about 23% had reported an increase in alcohol consumption. And if you look at just those individuals who said that they were really stressed out, then that was almost 40%. So 38% of those people who were stressed out said, yes, I've been drinking more. And of course, this isn't surprising to anyone in this room because you've seen it clinically. You've seen people coming into your office, not only reporting increased alcohol use, but then often experiencing the sequelae. Now, there are different ways that we can look at this. If we look at it from the perspective of risk factors, of course, there's environmental risk factors that have led to heightened use, such as not having access to as many healthy coping strategies, especially for adolescents, so school interruptions. At the level of the family, we see heightened levels of conflict, loss of support, economic strain, and of course, at the level of individual, there's the very real impact of boredom, isolation, and sadness and grief. Now, it's more than we can look more than just at self-report, right? We can actually look at some of the data like sales data. Sales data doesn't lie. And so if we look at cannabis, when I pulled this data some time ago, it just really pops out at you, right? If we look at, and this is along the x-axis, This is a month that taxes were sent in. So May reflects April sales, et cetera. And so what we'd see, of course, when we went, first went into lockdown in that kind of that March-April range of 2020, a 26% increase in 1 month in sales tax collections for medical cannabis. And as that graph, as you can see, that has not even come close to normalizing. There was a slight dip around winter, and if we stretch out that graph, we actually that's a fairly common trend that we see. But if we even look at when the pandemic began to now, there's been a further 45% increase in cannabis sales. And that's not fully accounted by increased licenses, even though there have been a lot of people. We actually saw a 29% increase in licenses over that same duration, but that compares to a 45% increase in sales. And I think about a case that I had who came to me several months ago, and this is a young guy, mid-40s, professional who had worked from home. And, because kids were having to homeschool, he was having to watch them. Well, that was pretty stressful. So he said, no, it's pretty easy. I'll get my card. And he began smoking cannabis. He'd, smoked a little bit of cannabis in college, but never had access to it on a daily basis. Well, this was different, right? So he began, and this is someone who's very intelligent, began using it daily and found, what, I do feel more calm, and picked it up. And then, of course, when he had to start going back into the office, he was shocked. He couldn't stop. He found that his work performance was impacted. He was at risk of losing his job. And this is someone who had really been kind of really well performing just a year and a half ago. And so, and I know that at least in my clinic, I've seen this play out time and time again, not just with cannabis, of course, but with other substances as well. If we look at alcohol, beyond just self-report, what we find is that sales have been increased. Behind, I have some national data that indicates, especially in that first quarter after the beginning of the pandemic restrictions, we saw a huge increases in alcohol sales of about 34%, and more recent data shows that has continued across time. And we've also seen the fallout from that. There's been studies that look at rates of alcohol withdrawal. And what we find is that, yes, there have been more admissions for alcohol withdrawal. Looking at my own hospital's data, and for reasons for ER visits, there was a 38% increase in alcohol-related ER visits compared to kind of what the previous baseline had been in the past fiscal year, which that is a huge increase. And of course, any of you who work in the ER, I'm sure are like, yes, I see this all the time. Not only that, but then we also see, unfortunately, the fallout from persistent or heavy alcohol use, not only transaminitis, but then unfortunately for some, overt hepatic or liver failure. I had another case who had been referred to me, who was a professional in her mid-50s, and she had drank socially as part of her job, but then with the lockdown had began to drink daily for the first time in her life. And it really, at first, didn't seem that much. It started as 2 glasses of wine, became about a bottle a night. But for her, that seemed okay. All of her peers seemed to be following a similar path. And, especially if we think back in 2020 and, in that June and July, that was kind of a common joke, about, oh yeah, we're all drinking and gaining our COVID weight. But for her, that actually ended up developing not only into an alcohol use disorder, but then, led to substantial hepatic impairment and, actually referral for, potentially need for transplantation. Thankfully, she's had enough residual activity where that was able to be avoided. But across the board, there have been increased referrals for need for transplantation related to alcoholic liver disease. Now, beyond the medical sequela from addiction, and other in substance use. When we look at overdose deaths, of course, that is where we've seen the most substantial increase. And it's not all COVID related. As I showed in those graphs, those rates were increasing before, but sadly, because of an interaction with these COVID-19 impacts on our daily life, increasing those risk factors, as we discussed earlier, we've seen a substantial increase, almost a 30% increase in deaths year over year. And this is a graph from the CDC, which shows regional variations. And Oklahoma is somewhere kind of in the middle of the pack, actually. So we have not been as severely impacted by this rise in overdose deaths as other part of the country. And I'll get to the reason for that here in a few minutes. If we look at some of the data that was available from the Oklahoma Bureau of Narcotics in coordination with the Oklahoma Medical Examiner, what we find is that overdose deaths for the first time in our state rose over 1,000 individuals in 2020. And of course, that has been a substantial increase from 2019. Now, if we look at what are the substances involved in overdose deaths across time, here in Oklahoma, we've actually looked a little bit differently. We've looked a little bit different than other parts of the country. So for us, we actually saw an increase in methamphetamine deaths, really kind of that have been slowly increasing across time, but actually surpassed opioid-related deaths beginning in that mid-July 2018 range. And even now, actually, psychostimulants, which are predominantly methamphetamine, those continue to account for the vast majority the majority of our overdose deaths. However, that may be changing because similar now to other parts of the country, which have been just wrecked by this increase in fentanyl-related overdose deaths, what we're seeing now in Oklahoma is that last year, fentanyl-related overdose deaths were increased by 150%. And at least, my take on that is that what we've been seeing in other parts of the country. So if we think back at that graph that showed the regional variations in overdose deaths for 2020, a lot of that actually overlaps with the regional variations that we see in fentanyl, especially fentanyl-related overdose. And so, as fentanyl shifts and we see more of it here in Oklahoma, my personal fear is that we will continue to see an increase in overdose deaths, and we won't be that nice little lighter shade of orange, but now will unfortunately probably shift to one of the more severely impacted states. Now, looking a little bit more in detail at fentanyl-involved overdose deaths, of course, fentanyl nationwide has been the principal driver of this. When we talk about it as a class, we're not only talking about fentanyl, but we're also talking about some of the analogs like carfentanil. We mentioned the regional variations. That actually tends to be most prominent in the Northeast and Great Lakes region. Southeast is kind of a close second. Most commonly, fentanyl is found as part of contaminated heroin or FASH, so fentanyl adulterated or substituted heroin. Sadly, I can think of a person who had been under my care that we couldn't really engage in treatment, who will be one of the numbers in this next year because of contaminated heroin. It's everywhere. And the reason why it's everywhere is because it's become cheap. So it's cheaper to produce than just straight heroin. It makes what would be kind of a lower grade heroin appear to be perceived as stronger. And it's more widely available. Lots of export from China, Mexico, India. And because of its potency, it's easy to smuggle because you don't need as much of it. It's also been found as a contaminant in methamphetamine, as well as in counterfeit pills. And that's not only like counterfeit oxycodone, but even in counterfeit Xanax, which of course is very dangerous because you may have someone who has no tolerance whatsoever for opiates, who then may take what's a very potent and very dangerous dose. And of course, the criminals out there are always a few steps ahead of us. And what we find is, in addition to it being more widely available, it's actually not hard for people to counterfeit pills. You can find this stuff on eBay or Etsy, pill molds. I think it was like, what is it, $25, and that was the nicer version. And so, sadly, then, we see, what's present on the right side of the slide, which is the real impact, right? There not only the counterfeit pills, but the fact that, yes, in our state, we've had several people die from these, fentanyl-containing counterfeit pills. So, what do we do about this, right? I'm not just going to try and doom and gloom and talk about what a difficult and tragic problem this is, but I think it's important for all of us as physicians to see what can we do about it. Well, most clearly and most immediately, a strategy that may be useful is looking at harm reduction, and especially naloxone. Of course, you all know that naloxone is a competitive inhibitor at the opioid receptor with strongest affinity for the mu opioid receptor. And there's the nasal version. Narcan is approved about 6 years ago. There's a generic available now, which has been so nice because it's driven down the cost a little bit. And there's good evidence. Obviously it works when you give it to someone, but there's also good evidence for distribution programs. The distribution programs in British Columbia, one in which just in the first few months of a program that distributed about 20,000 kits, they estimated that it saved about 300 lives. Follow-up study 3 years later showed that about 40,000 kits had been used. We also see that just the laws themselves that expand access to naloxone have been associated with a decrease in opioid overdose deaths. And some statistical modeling shows that about 1 out of 5 opioid overdose deaths could be averted by more widely distributing naloxone. And who should receive? Well, of course, anyone with a history of overdose, those with substance use disorders or a history of substance use disorders should have it accessible. Those who are prescribed opioids, especially more than 50 morphine equivalents, or those who are taking opioids in combination with benzodiazepines. People who use drugs, they should have it. And it's not just people who use opioids. I'm now writing, naloxone scripts if I have a person who is using methamphetamine. And, there's a study that was in the MMWR a couple of years ago outlining some of the fentanyl deaths in Massachusetts. And, there's not just IV use. People are dying from snorting or from smoking because of the high potency. So, and then, as importantly to distribution to those who use drug, being able to distribute to people who are acquaintances of, friends of, family of, people who may use drugs. And the really nice thing is that it's actually pretty widely available now. You can get it from the pharmacy with or without a prescription. There's ways to get it in the mail, as well as distribution centers, community mental health centers. Many of them participate in the state's naloxone program, and it's free for the patient. There's distribution events where naloxone will be handed out. If you want to share this resource for your patients, okimready.org. All they have to do is fill out an online form, and they will have naloxone delivered to their door. And if they don't want to do something that's state because they're paranoid or concerned about their information getting out, there's also another nonprofit called nextdistro.org that will send out free naloxone. The other thing I like about OK I'm Ready's website is it has training videos. Of course, it's one thing just to say, oh, hey, here's some naloxone, but you probably need to know how to use it, the importance of having a second dose handy just in case that first one's not fully effective, especially if we're thinking about some of the synthetics. And so there are actually pretty good videos out there to be able to share with your patients or their family. Another helpful thing that some people may find effective, a little bit more controversial, are fentanyl test strips. There's not a lot of evidence. These haven't been studied in any major large trials. They have looked to see, are they effective at testing for fentanyl? And the evidence is good for that. But, in terms of, mortality benefit in communities, we're not quite sure yet. The evidence isn't, it's not, hasn't been published. However, I do wonder about indirect effects, right? Because if we're talking with a person who is engaging in a possibly very dangerous behavior, just getting them to accept that there's danger in that behavior, even if it's by using a test strip, you're not necessarily encouraging their use, but they are beginning to accept that, yes, this could be something that is, that could have a very bad outcome. And realistically, if you have a patient that you're working with that's using, either methamphetamine or using opioids or, injecting heroin, one question that I'd love to ask is one, have you ever had any close calls? I don't use the word overdose because they often will push back against that, but you can use, have you ever had close calls or bad reaction? And then the other really telling question that I think, is great to be able to start that cycle of motivational interviewing is ask them, have they ever seen someone have a close call or an overdose? And, even now, I'm amazed at how consistently I get the answer of yes. And man, that really initiates that important conversation. So, in addition to, being able to give out, and increase access to naloxone, we also want to be identifying those who are at most risk. Those people who are at highest risk for opioid overdose are those who have immediately completed a detox and aren't on any types of maintenance medication. Those who've been released from some incarcerated setting, those who are using multiple substances, those who are using IV. We're not quite as clear about what the risk factors are for fentanyl-related overdose, other than frequent drug combining and those who may express a preference for fentanyl. I saw my first case, actually, of probably 3 months ago, of a young lady who came out from California who said that she actually looks for fentanyl on the street, which is just terrifying. But this is something that, especially in other parts of the country, we've been seeing. In some parts of California, the rates of fentanyl preference were around 25 to 30%. And so my fear is that we'll see that shift here as well. And of course, social factors we know are associated with overdose deaths. Economic insecurity, unstable housing, unemployment. And many of these, you'll note, probably are even heightened right now during the COVID-19 pandemic. When we look at being able to really prevent overdose deaths and do it in a consistent manner, it's not just about harm reduction. Of course, we want to identify those who are having problems and be able to initiate some type of treatment. I'm sure many of you have heard of the SBIRT intervention. SBIRT, just an acronym: screening, brief intervention, and referral to treatment. Mainly just involves using some type of screening instrument to identify those who are using substances or alcohol in an unhealthy pattern, and then being able to triage them and get them into the appropriate care they need. Two instruments that are very helpful for that you can easily just include in the clinic flow include the Audit C as well as the DAST. Those are two that I often recommend. The evidence actually, even if the DAST has too many questions, if you're afraid that it'll kind of slow things down too much, there's been some study that a single question screener, which basically says, in the past year, have you used any drugs for non-medicinal purposes? Actually has just about as good sensitivity and specificity as the DAST screener. In terms of how good are they? Because I think that's the question that comes up often, right? You're like, okay, is my patient really going to tell me the truth if I give it to him? We actually find it's not too bad. The sensitivity of the audit C with a cutoff score of 4 in men is around 86%, which isn't horrible. Specificity of about 0.89 is actually better than the PHQ-9, the numbers on it in terms of efficacy for screening for depression. For women, the numbers are a little bit lower. We find the sensitivity is around 73% with a cutoff score of 3, with a good specificity of 0.9. Now, obviously, if we have someone who screens positive, there are additional steps, one of which, of course, is a good interview and clinical exam and looking at these SUD criteria that we've already reviewed to some extent. And then the next steps, what do we do for those, who we decide, they do have a substance use disorder. Ideally, we try to approach it, just like we would any other chronic disease. And we really look at, involving as many modalities as we can because it's difficult to treat. And, we know that not only is it difficult to treat, but a lot of people actually don't receive treatment. About 1 out of 5 individuals with a substance use disorder don't receive the needed treatment. Of course, from our perspective as physicians, there are medications that we know that can be helpful. And that is a tool that, many of us may employ. If it's alcohol, I'm sure you've seen this both in terms of good evidence for naltrexone as well as acamprosate. I don't find myself prescribing a lot of disulfiram. I don't think I have too many patients that have been interested in that. But certainly naltrexone and acamprosate, have good evidence. There's also, it's not FDA approved, but there is some evidence that topiramate or Topamax can be helpful in patients with heavy alcohol use or alcohol use disorder, and uniquely may in cutting back the number of heavy drinking days. Interestingly, that response tends to be most robust in people with a specific genetic polymorphism that predisposes them to alcohol use disorder, but it is a helpful option to keep in mind. I'll talk a little bit more in detail in a few moments about the medications that we have available for opioid use disorder. Methamphetamine, that's something, unfortunately, we don't have any FDA approved medications for. There have been tons of medications studied, none of which have had really a strong or robust effect. Until here recently, there was a positive trial for a combination of bupropion and naltrexone. The numbers weren't great in terms of abstinence, but it was much better than placebo. Placebo, I think, had a response rate of in the low single digits, like that 3 to 5, whereas the combo medication was in the low teens. So it was better, but still leaves a lot to be desired. And then cannabis, there's some weak evidence for gabapentin, nothing that I prescribe on an ongoing basis. But when you have that person who is really struggling, they may not be able to engage in other types of treatments. I've had a few. In fact, the person I was had referenced earlier, who on a very low dose, like 100 milligrams, had done well in addressing some of those strong cravings that someone who's actually developed a physiologic dependence to cannabinoids can sometimes experience. One of the more important things as we look at getting someone into treatment, is what do we do with them? What setting is most appropriate? And there are some assessments that we in the addiction field will utilize to try and match a person with their with their preferences and their needs. And those may, I won't go through, it's called the ACM criteria in case you ever hear an insurance company throw that back out at you. But really what those criteria look at are, broadly speaking, what's that person's potential to have some type of significant withdrawal? What are their underlying medical comorbidities? What are their psychiatric comorbidities? Are they ready to change? What's their relapse potential? And what is the addiction speak for it is recovery environment, but what does their living environment look like, right? Is the spouse also caught up in addiction? And so I think it's important that just we look at this, as physicians, because, if we're referring someone to treatment, And, we're not sure if insurance is going to say, yes. These are what often insurance companies are looking at, these different domains. Now, once we kind of look at, these different areas and really kind of what's that person's needs, is it someone who, may have had a strong history of withdrawal delirium and seizures and needs medical admission? Is it someone who's, we're catching relatively early in the course and they're appropriate for a lower level care like outpatient? The different levels to be mindful of. Residential treatment is, after kind of, if we think of hospital admission, residential treatment is the more intense. That means where someone's living there, kind of what we would often think of like rehab, where it's, continual services. Someone's there 24/7. There's usually a physician, nursing staff that's available. The next level is partial hospitalization. And partial hospitalization programs involve still kind of a daily program usually, where it's about 20 hours a week. Some do 4 days a week. It's not a live-in. People are still living at home, but they're coming in for some type of usually group intervention, some individual therapy, meeting with a physician. And then less is the intensive outpatient, where we're kind of stepping someone down in terms of a lower intensity of care. And so we describe this as really a continuum of care. And it's really helpful because, many individuals don't recover in a straight line if we think about addiction treatment, right? Some people may, really need residential treatment and then they're doing better and we can step them down, but maybe something happens. Maybe their spouse decides to leave them and they may start using again. And so then we need to step them up into a higher level of care. So really now the field has begun to look at it in terms of a continuum. A tool that I often find helpful, because the question often is, well, where do I send someone for treatment? I mean, I'm an addiction physician, but I still have to refer people all the time for different levels of care. And so, I really like this tool by SAMHSA, and you can just find treatment.samhsa.gov to be able to type in the patient zip code. You can limit it by treatment providers, the types of services you're looking at. And it may actually do a pretty good job keeping it up to date. So I found that to be very helpful. When we look at specifically treatment for opioid use disorder, out of curiosity, does anyone here have their X waiver to be able to prescribe buprenorphine? Okay, awesome. So a few of you do. Well, the great news is that if you don't, it's actually a lot easier now to be able to do that. For those of you who do, you got stuck having to do the education, but it's still probably, hopefully was helpful. But what we see now is that actually with the updated guidance related to not just the pandemic, but this epidemic of overdose deaths, Health and Human Services is now waiving the education requirement for anyone who is wanting to treat up to 30 patients. So what that hopefully will do is open the doors so that more people can respond to that patient who may come into your office needing help with an addiction to opiates. Of course, there's three options we have: buprenorphine, methadone, and naltrexone. I should say the naltrexone that's effective for opiate use disorder is really only the long-acting version, the Vivitrol. Oral naltrexone hasn't been shown to be all that effective because people just stop taking it. And most importantly, buprenorphine and methadone are showing mortality benefits. So just a recent study published from the VA that was a longitudinal 9-year study looking at buprenorphine found a 4-fold decrease in the risk of death among individuals who were currently prescribed buprenorphine, compared to those who weren't. So, and that wasn't just of overdose, but of suicide as well. There's also been recent studies that look at individuals who present to an ER after a non-fatal overdose. And what they find is that in this population, those who had at some point in the next month, connected with a provider either at that time of the ER visit or shortly thereafter, and were prescribed either buprenorphine or methadone, actually had a significant lower risk of death, both death related to overdose, but also more broadly, overall mortality. And concerningly, they did not find that same association among, among people who'd been prescribed Vivitrol or long-acting naltrexone. And the researchers felt that that was most likely related to challenges in continuing that care, like where people, they would more commonly drop out of treatment who had been prescribed naltrexone. And that's consistent with what we know as part of the data as well. Buprenorphine, of course, is a partial agonist with strong binding affinity. It's strong enough that it can actually precipitate withdrawal if you give it to someone who has lots of opioids already on board. Has somewhat low intrinsic activity, the mu opioid receptor, and so therefore it doesn't have it doesn't cause a euphoria like a morphine would or something else for individuals who are already physiologically dependent upon an opioid. There are different formulations. We're all most common with the oral sublingual. Now there's actually a long-acting version of buprenorphine. The trade name for that is Sublocade. I've yet to get a patient to give the okay for it, but insurance is starting to cover it. And so, in addition to being something that's non-divertible, it's also, I think, at least in my own opinion, may be useful from a psychological perspective in not having to take something on a regular basis, and then maybe even eventually being able to help someone who is in a place to be able to stop, to be able to do that. I mentioned the HHS updates. So if any of you, if you're not waivered, if you just happen to have a person who comes in and you're like, man, they really need buprenorphine. The way it's set up now is that you can actually, just go to the website and file a notice of intent with the DEA. And there's even a box to check. It's a really short form, doesn't take more than 5 minutes, which is remarkable for any government form. But you can even indicate that you have someone that you'd like to treat same day. And so that way it makes it more accessible, just in case you have someone who shows up and you feel like really needs treatment. We still all have to do this X waiver. There is a really strong movement right now to get rid of it and really treat buprenorphine like we would other medications. But it literally requires an act of Congress because buprenorphine was allowed to be used in office-based settings by the Data 2000 legislation. So if you do decide to put someone on buprenorphine for addiction, you can use it for pain, but if you do it for addiction, you have to make sure and fill out this application and at least apply for that X waiver. That covers you for up to 30 patients. So getting started, it actually isn't that hard, and I'll hurry up because I know that I believe the reception is waiting. So basically, it's not complicated. You wait until someone is in a moderate withdrawal, which a lot of times when they're coming to our office, they're coming there because they're already in moderate withdrawal. So if they're there, I use a CAL score. If that CAL score shows that they're in moderate withdrawal, then one, you can be pretty confident that they meet criteria for at least a moderate, that they have a physiologic dependence on opiates, which is one of the most important things before you're starting buprenorphine. You're certainly not going to precipitate withdrawal if they're already in moderate or severe withdrawal. And so, you give them a dose of 4 milligrams of buprenorphine. 2, if you want to be a little bit more cautious, you check in with them in an hour. Have you made it worse? No, then they're not in precipitated withdrawal. You check in a couple hours later. Or is it resolved? Yes or no? If it's not, then you give them a little bit more. Check in with them the next day. It's not too complicated. So, and like I mentioned before, it can be life-saving. Maintenance, what we do is we take the first couple of days, see how they do. A maintenance dose usually is somewhere between that 8 and 24 milligrams. And really we utilize it as long as a person needs. I won't bore you with a bunch of stories, but I can tell you that in my career, some of the most dramatic changes and recoveries in function have been patients who I've had who have come to me, dependent on opioids, getting on treatment, and then watching them just flourish. Most notably, I had this dad I was treating who had been like unemployed and had been kicked out of his home. And, we got him on treatment. He reconciled and he came to my office and he sat down and he would just like had this look in his eye. And And I said, well, what's going on? He said, I can say that for the first time in 5 years, I looked across the table and I saw my children. And man, that just hit me. And, and I'm sure that, that those of you, who have used buprenorphine, I've heard my colleagues have similar stories. You just see people do really, really well. Of course, prevention, not that we're going to be doing this from an office setting, but, a lot of us often are asked to give some type of advice. There's definitely some preventive efforts, which will be really important in the years to come. And beyond, beyond just looking at preventing overdose deaths, we also, of course, it's important to keep in mind suicide. Suicide rates actually dipped a little bit last year. I have no idea what's going to happen this year. But, that's our patients with substance use disorders have that heightened risk for suicide. So, using good risk assessments, using tools such as safety plans. Here are some resources that I often share with my patients. The Suicide Prevention Lifeline, the text line. I love the text line, especially with my younger patients, because they're going to be much more likely to text than to call. And then there's a couple of apps, the Virtual Hope Box, My3, both of which are really user-friendly, and I've had patients really find to be helpful. So with that being said, and sorry, I think you may be a few minutes late to the reception. What questions do you have for me? Yes. That's a great question. So have we found acupuncture to be beginning to utilize for addiction? We have. It's there are some smaller studies that have shown that to be helpful. It's what I would say is that it's probably most helpful as an adjunct and probably not. It's not going to take the place of something such as buprenorphine or methadone. But, when we look at, its role is kind of augmenting, then I think that that it's certainly something. I wouldn't discourage a patient from doing acupuncture. Probably, even more interesting are some of the mindfulness-based interventions that we're seeing implemented in addiction treatment. There is a type of a therapy called mindfulness-based stress reduction, MBSR, and really good response rates, for patients. I kind of flew through some of those slides, but many of us, one of our reflex things we do if we have someone with addiction is refer them to AA, and there's good evidence. We know that AA can be very helpful, AA, NA, but then there are also options for those who may. I'm sure that you've all, like I have, heard the person, oh, I don't like that AA stuff. I don't believe in a higher power. Well, the good thing is that there's other options now. There's smart recovery, which takes a little bit more of a kind of a pragmatic approach. And for those that may be more, who identify more strongly with like mindfulness skills, there's something called Recovery Dharma, which I have had a lot of patients really feel that they benefit from. And of course, those that prefer a faith-based perspective may really connect well with Celebrate Recovery. So, I actually love it when I get that pushback from a patient about, oh, I don't like that AA stuff. I'm like, oh, well, you know what? That's okay, because we have all these options out here that we can discuss. But thank you for the question. Any other questions? All right. I think this was strategically placed right before cocktail hour. So
No accidents.
well, thank you all for attending.
Jed, that was wonderful. Thank you for your time.